We do have a very exciting session for you all this afternoon. We have a number of abstract presenters from nurse practitioners working in various areas. There are some overlapping themes, which will hopefully make for some really interesting discussion amongst our NP presenters as well as those in the audience. We will have time for questions and answers after each presentation. You can feel free to use the chat function, or we will ask you to raise your hand. If you would like to unmute yourself, you can ask it directly that way as well. A reminder to the participants, you will have no more than 10 minutes to go through your presentation, and then we'll have a couple minutes at the end for questions and answers. So without further ado, we will get started. I want to make sure that Jane is joined us already.
Yes, I'm here.
Okay, wonderful. Hi, Jane. How are you?
I'm good, thank you. Hi, everyone.
Jane, I'm going to start actually with introducing you quickly. Okay, so, and I have your slides as well, so you can cue me as soon as we get started in terms of advancing your slides. So Jane started her career as a nurse practitioner in 2017 and has worked in both primary care and acute care settings. She started at the Don Mills Family Health Team and subsequently specialized in the hematopenic, you're gonna have to correct me possibly, stem cell transplant program at Princess Margaret Hospital. Currently, her main role is in the complex malignant hematology program at the Durham Region Cancer Center. She also practices primary care in a virtual setting at Dialogue and as a sub-investigator for Novum Pharmaceuticals on a casual basis. Lastly, Jane is also an adjunct lecturer with the Lawrence S. Bloomberg Faculty of Nursing. So Jane, thank you so much. I will let you take it away.
Thanks for the introduction. So I know I don't have a lot of time, so I'm going to try and just dive right into it. Next slide, please. So first, I'm going to explain what the complex malignant hematology program actually is, and then go ahead with the second section, which is basically the goals of care as a nurse practitioner in this role, which I'll go into in a bit more details as we get into the slides. Next slide. Next slide. So I want you guys to take a look at this quote. It is a really powerful quote, and it essentially started with a plea for help in 2016 from an 18-year-old Burlington teenager with acute leukemia at the Juravinsky Center. So this girl, during the course of her treatment, she had received unnecessary chemotherapy to buy time until a stem cell transplant bed was available. But of course, as she continued to wait, her disease came back and mutated and became more aggressive. And eventually she did pass away. So this incident right here really highlighted the failure of the system with respect to funding, operational challenges, and access to basic complex malignant hematology services, including chemotherapy and specialized personnel. So just to give you an example, with international standards, patients should really have their transplant within 2 to 3 months of their diagnosis. In her case, the expected time frame was 6 months, and at Princess Margaret Hospital at that time, it was 8 months for a transplant bed. So this really led to the creation of the Ontario Health Cancer Care Ontario CMH consultation group in 2016 as a response to the urgent need for how changes needs to be made in terms of treatment across Ontario. So this group essentially provided advice to the Minister of Health on the development and implementation of a provincial strategy to address pressures in complex malignant hematology care. Next slide, please. So essentially, complex malignant hematology speaks to various cancers of the blood. So lymphoma, myeloma, leukemia, for example, they're often quite complex and they're often evolving, and this does require a lot of intensive resources and specialized facilities. So as a result of these demand, the rise in complexity and weight.
Just gone on mute there, Jane.
Sorry, did you mute me?
Nope.
Oh, okay. I just got muted, so I'm not sure how much you guys heard. Did you want me to go over the slide again?
Yes, please. Thank you.
Okay. So essentially CMH refers to a lot of different type of hematology of the blood. So for example, lymphoma, myeloma, and leukemia. And these these cancers really require a lot of intensive specialized treatment, and a lot of facilities just aren't set up for that. So as a rise in these services, this does offer opportunities for nurse practitioners to try and use their knowledge and expertise to try and meet the healthcare needs of individuals and family members. And in order to address these needs, Ontario Health did provide funding in September of 2018 after this initial incident in 2016 to regional cancer centers to try and implement the NP in the complex malignant role. Next slide, please. Next slide. So as a nurse practitioner coming into this role in the Durham Regional Cancer Center, it was a newly funded position at that time. And I really did try my best to promote the awareness of the NP role. It was a completely new role to the cancer center. So, there was some pressure to try and do well so that in the future, when hematologists and other healthcare professionals come across other NPs or the NP designation in particular, they'll see this in a positive light. So I really tried my best to develop this role over time. And the plan was really to ensure that the NP remained mutually beneficial to all parties involved, including hematologists, allied health members, and most importantly, the patients and their family members. And this process began with the creation of a collaborative practice agreement and medical directive. So this introduced and promoted the awareness of the NP role in the Durham Regional Cancer Center. It helps to set out the roles and responsibilities of the NP versus the hematologist and sets out expectations right from the beginning. And a medical directive in the hematology world is also really important, given that we're not yet able to order CTs and MRIs, which can be crucial for this population. Next slide, please. And in terms of building capacity and expertise, because these are very specialized services, the Cancer Care Ontario did provide funding for an NP like myself to go and pair up with experienced NPs from other sites like Princess Margaret Hospital for 6 weeks. So this allows for the transfer of knowledge and experience. And by doing this, it allows the traditional transplant and acute leukemia sites such as PMH to reduce their capacity and enables community hospitals to become an acute leukemia shared care partner site. And not only does this help the transplant centers that are overwhelmed, but by extension, this also provides timely access to patients closer to home. And as a result of this mentorship now, I currently have clinic space in which I provide CMH services, including symptom management and transfusion support. And part of my quality improvement project now to submit to Cancer Care Ontario is to look at the patient volume that I see as an NP and whether I've improved access to care. And these data will be analyzed and submitted to Cancer Care Ontario in the future. Next slide. So I'll also be looking at data to see if having an NP in the Durham Cancer Center has reduced ER visits. That's one of the most important indicators that we're looking at in acute care. And I'll be looking at the numbers of patients I've admitted through the urgent care clinic and thereby allowing the patients to bypass the ER. Next slide, please. And then lastly, I'll also be looking at data on whether patients and providers, both hematologists, hospitalists, have had a satisfactory experience with having an NP in the program. So again, all these data have already been collected. So for example, I have about 15 patients who did the survey, 4 hematologists and 16 hospitalists. And so far, results have been quite positive. Next slide, please. So the creation of the CMH program has really led to new models of care. So it is a growing program. Lake Ridge Health was essentially the guinea pig with respect to this because we established the first CMH program in the community. And CMH programs are now actually being started out at other community hospitals such as South Lake as well as RVH. And all of this really allows NPs and nurses to engage in leadership roles with the potential to really make a huge difference with the proper resources and education. Next slide. So that's pretty much it. Do you guys have any questions?
Any questions for Jane? You can either go directly into the chat or you feel free to unmute yourselves as well and we can have a conversation. Thank you so much, Jane, for providing some background into your project. It sounds very interesting and also very complicated, but hopefully worthwhile in the end for your patients. Absolutely.
It is. I think the most important piece of all of this is that patients are now able to access such specialized services closer to home.
Absolutely. That's amazing. Thank you so much. Okay, so in the absence of any questions, we will move on to our next presentation, which is by Eric Rankin. So Eric, I'm going to introduce you as well. Eric Rankin is a settler Canadian who, lives and works in Hamilton, Ontario, the traditional territory of Anishinaabe and Haudenosaunee peoples. Eric is a primary healthcare nurse practitioner and works in this capacity at Dina's Aboriginal Health Centre in Hamilton, Ontario. Eric is currently pursuing a PhD in nursing with a focus on Indigenous health and health equity. In Eric's spare time, he is a volunteer with the Canadian Medical Assistance Teams and outgoing board member of the RNAO. Eric is married to a beautiful wife and is a proud father of 4 adorable children. So welcome, Eric. I will guide you through your slides on your cue, and please do correct me for my mispronunciation. I need to work on that more.
That's okay. That's okay. Hi, everybody. Some may know me. Some, for those that don't, I'm Eric Rankin. Thank you for the introduction, Catherine, and for the opportunity to present this good work. I am from the traditional territory of the Anishinaabe and the Haudenosaunee nations, and it's within the lands protected by the Dish with One Spoon Wampum Agreement. I say this land acknowledgement not for tokenism, but for the good work that is being done through this study, as well as all of the other activities that I continually reflect on as an ally for Indigenous peoples. Next slide, please. Today, I'll be talking about the scoping review, part of my doctoral work, one of the first steps in the doctoral work for my focusing on the role of the Indigenous patient navigator in Canada. The first, this scoping review is focused more internationally in Australia, New Zealand, Canada, and the United States. Just to provide some background for those that may not know, from a Western or in Western society, the role of the patient navigator has been broadly known as a patient-centered approach to empowering individuals and families to establish connection to appropriate services. Given our very complex health and social services, this is an area that the navigator can help to navigate and has been identified as a role that can help to address those barriers. The term navigator was first devised in Harlem, New York in the 1990s by Dr. Harold Freeman to assist marginalized populations, particularly Black African-American women, to address health and social complexities, particularly around cancer prevention. Navigators can be either lay or peer navigators, or they might be professional navigators, like, for example, a registered nurse or a social worker. And certainly the role, or the, I guess the kind of activity of navigation is part of many of our jobs on a daily basis, but the role of the navigator, and particularly an Indigenous patient navigator, is to help navigate the system and address barriers. So why is this role needed, particularly for the Indigenous community? I mentioned about the role, the navigator role addressing social determinants of health, or the specific Indigenous social determinants of health, which help to identify and on a much deeper level and more profound way as far as the historical injustices that have been experienced by Indigenous peoples. Next slide, please. It's estimated that there's between 370 to 500 million Indigenous peoples from over 90 countries from around the world. Health disparities among Indigenous populations are increasingly disproportionate in comparison to those of the non-Indigenous communities. I want to share with you a few stories, and these stories help to identify the experiences of systemic racism and also structural violence Indigenous peoples face while accessing health and social services in Canada. The first story is the story of Brian Sinclair, an Indigenous man who died in an emergency department in Winnipeg's Health Sciences Center in 2008. Mr. Sinclair was sent by taxi to the ER from his primary care physician's office for further assessment and care. Mr. Sinclair died of complications of a treatable bladder infection after having been ignored, unattended to, and uncared for during his 34-hour period waiting in the emergency room. An inquest was initially refused by the Manitoba government, but eventually 5 years later, this inquest was completed. The presiding judge ruled that the issues were related to race, racism, poverty, and disability, and substance abuse, and that they were beyond the mandate of the inquest, which was the purpose of this particular story. Another story of racism and social injustice is the Michaela Salt, an 11-year-old Ojibwe girl from New Credit First Nation, who was asked to stop chemotherapy treatment for acute lymphoblastic lymphoma and opted to, or she decided to stop that treatment and opted for Indigenous traditional medicine in the spring of 2014. Michaela's story ignited debate among the validity of Indigenous medicine and the rights of children to choose their own treatment. Michaela, her parents, and her siblings were informed by her oncologist at McMaster Children's Hospital that the children would be apprehended by Child and Family Services. Eventually, they were told that they would not be able to practice or be cured by their traditional medicines, and that they could be thrown into jail. A final story is the one that's more recently been published in the newspapers around Joyce Echaquan, a 37-year-old Atikamekw woman who died in September of 2020 in the Center of Hospital de Laurier in Saint Charles Borromée, Quebec. I probably have not pronounced that correctly. Before her death, she recorded on Facebook Live video stream showing her screaming in distress while healthcare workers abused her. Mr. Sinclair, Miss Salt, and Miss Echaquan's story are not unique to the experiences of Indigenous peoples in the healthcare system. Stereotypes and preconceived notions around Indigenous peoples are embedded in our healthcare system. Indigenous health differs from the mainstream population, and it's more conceptualized as a collective rather than an individual. Indigenous communities from around the world continue to practice traditional healing methods and manage their collective health. However, health and social disparities have greatly affected their ability to navigate complex healthcare systems, requiring and necessitating the role of the Indigenous patient navigator. While navigator programs certainly do not address these system issues entirely, they will and can help to allow patients to navigate the system, address racism, and also support patients along their way. Next slide, please. The purpose of the scoping review, again, a first step of my PhD work, focusing on the role of this Indigenous patient navigator in addressing health inequity, is to understand and explore the role of the Indigenous patient navigator in Canada, United States, Australia, and New Zealand. There are threefold. I won't read them entirely, but basically to understand the extent of research in these countries around this role, to examine the Indigenous patient navigator role and how it specifically addresses barriers faced by Indigenous community members, as well as addressing any potential gaps in the literature. Next slide, please. The methods that were used for this scoping review was a 6-step methodological framework outlined by Arsky and O'Malley, and also through the PRISMA, most recently the PRISMA guidelines around scoping reviews. A robust and complete search strategy was initiated in consultation with the librarian, and key search words were used. You can see there are 4 key areas for search: Medline, CINAHL, Web of Science, and iPortal USask, which is an Indigenous-specific search engine. Articles were excluded if they were not clear of the role of the patient navigator or that the navigator addressed barriers. There are additional inclusion and exclusion criteria, but I won't go through those just for the sake of time. I will mention that 2 reviewers were involved with the article selection. The second reviewer, who does identify as a First Nations individual. Also, additional stakeholder consultation was also employed with a supervisory committee, which involves more than half Indigenous community members. The findings from this study mainly identified 6 main areas of roles that the Indigenous patient navigator takes on. The first that being holistic support of Indigenous peoples, the first being social service navigation, second, holistic support of Indigenous peoples, third, advocacy and capacity building, fourth, health assessment, fifth, administrative navigation, and then finally, outreach. There are more specifics. I won't get into the specifics of the activities within each of these, but I can certainly share my slides with you also. I will mention some of the key findings that were not identified as far as the particular roles, which was one objective of this scoping review. No published literature was found from Australia, which was quite surprising considering cultural competency has originated in that particular country. One published article was found in New Zealand and uniquely identified addressing barriers around land claims, which was a bit unique compared to other articles. The term navigator was most often used within the literature. However, many other terms were also used, including advocate and more specific terms like children's oral health aides. And in those cases, you can imagine the ambiguity around this role and the ability to describe these roles. The key findings for this particular role was to be able to identify both practice, policy, and research impacts. So first of all, under practice, understanding the role of Indigenous patient navigator will assist to build interdisciplinary and collaborative teams to improve health and social well-being of Indigenous communities. Policy-wise, mapping the role of Indigenous patient navigator will assist political and decision makers to make informed decisions around funding of this role. And I'll certainly be talking to our previous presenter about that with Ontario Health. Finally, under research, the scoping review is the reason why it was unique and novel was because there's been no other scoping reviews of this capacity, particularly focusing on these 4 countries. More importantly, the further research and the research that's being conducted currently around understanding this role of the patient navigator in Ontario and across Canada has not been done before. Finally, while the solution for this problem is complex, with deep connections to intergenerational trauma and injustices and the implementation of assimilative processes and policies, improving access to health and healthcare services, whether Western biomedical or access to traditional healing models, or even connection to community. This ongoing research within this area to address the gaps of health and equity for Indigenous peoples is pertinent. Once again, my name is Arik Rankin. This is just a small snippet of my doctoral research. I'd be happy to answer any questions should you have them.
Thank you so much. That was a really great overview of the first step of your doctoral work. I'm sure that this is exciting for you to at least have this under your belt, and there is much more to come, and we will definitely look forward to what is to come from your research and further work, and of course very excited to be able to connect you with Matt. Are there any questions from the audience? I wanted to ask you, Eric, is there any discussion around this type of navigator role in the workplace you currently work in, or I guess it would be most appropriate to be in a setting that isn't directly focused for Indigenous people?
Yeah, no, that's a really good question, Catherine. So we do have a Indigenous patient navigator role here at Deidwaada Desnes Aboriginal Health Center in Hamilton, as well as we have a Brantford site and a Niagara site. So we have a patient navigator at each one of those sites. They are lay patient navigators, and there are also navigators available in case anyone, my NP colleagues, are looking to connect with one through NIHB, so non-insured health benefits have their own navigators, as well as Cancer Care Ontario.
Wonderful, thanks. And if you could imagine how those navigators might work in the stories that you told at the beginning, how would you see that outcome differently for each of those people?
Really good question. So, I'm reflecting back to, because I'm currently in data collection mode, so many of these questions are in my head, answers from Indigenous community members as well as patient navigators. And so some of the feedback, kind of a little snippet ahead of time before the final study, is around feeling comfortable. So having that, first of all, in hospitals, if someone does self-identify, having that ability for an individual to self-identify should they want to, and then be offered a connection to an Indigenous patient navigator. That then from that connection can carry on those roles, as I mentioned. But having heard from patients as well as the navigators, that bridge and to connecting them and overcoming those barriers, and also the confidence that is enabled for community members to have someone, whether or not they're from the same community or not, be able to advocate on their behalf, or even navigate in some cases, the ability to fill out complaints for racist experiences.
Absolutely. Thank you so much. We do really appreciate it. Awesome. Okay, we will move on to our next presentation. And we are featuring Julia Villagenova. Please correct me if I have mispronounced your last name, Julia. So Julia is a nurse practitioner specializing in the Division of Thromboembolism at St. Joseph's Healthcare Hamilton in Hamilton, Ontario. She started her career as a registered nurse in 2009 and has worked in several specialty areas, including medical, surgical, critical care, and dialysis. In 2014, she graduated from Ryerson University from a combined Master of Nursing and Primary Care Nurse Practitioner program and has since focused her career in the area of thromboembolism. She is currently in pursuit of a doctorate of nursing practice degree at American Centennial University. So welcome, Julia, and I will pass it over to you now to get us started.
Hi, everyone. Thanks so much for having me here. I'm pleased to present this abstract on behalf of myself and my nurse practitioner colleague, Lori Sardo. Next slide, please. So Lori and I work in the thrombosis program at St. Joseph's Healthcare Hamilton and split our time evenly between the inpatient service and outpatient perioperative anticoagulation clinic. St. Joe's is a tertiary care university-affiliated hospital located in Hamilton, Ontario. The clinic offers perioperative management of anticoagulants for patients having surgery or invasive procedures. It runs 3 days a week and traditionally sees about 850 patients per year. Our team consists of a thrombosis nurse practitioner, a physician, and some very limited administrative support. In December of 2014, nurse practitioners were introduced to the clinic to replace registered nurses. The rationale was that NPs could independently assess, manage, and execute treatment plans, order lab work, and had prescriptive authority. Soon after this role change, there was a request from the medical director for increased clinic time to help manage urgent consults and a wait list that kept growing by days. This presented an opportunity for change, so we decided to hop right on it. Next slide, please. To guide our quality improvement project, we decided to use the Institute for Healthcare Improvement's QI model called the Model of Improvement. It consists of 2 parts. First, there are the 3 fundamental questions for improvement, and then the PDSA cycle, which I'm sure most of you are familiar with. Together, these make up the model for learning and change. Next slide, please. Sorry. I'm sorry. So the first question is goals. So what are we trying to accomplish? I apologize, everybody. There are a few animations that I did not remove for this presentation. I'm sorry.
No worries.
And one more. Thanks.
No problem.
So the first step we decided to take was to basically just observe what's going on. So the current process, and we did this for several months prior to prioritizing and choosing our goals. Our ultimate goal was pretty simple. We just wanted to make sure we increased efficiencies in the clinic. To do this, we wanted to increase and maximize clinic capacity. So increase the number of patients that we see, decrease the no-show rate, which was going through the roof, and eliminate the wait list, including urgent consults. Our second goal was to improve patient care. So we wanted to improve patient care by minimizing the no-show rate again and reducing unnecessary blood work while maintaining low rates of delayed or canceled procedures that happened as a result of the wait list because we couldn't see people in time for their surgeries. Next slide, please. Third, we hope to realize economic savings by maximizing the NP scope of practice and minimizing unnecessary lab work. And finally, we wanted to make sure that physicians were actually satisfied with the care we provide to our patients. Next slide. The second question focuses on measurement. So how will we know that a change is actually an improvement? Next slide. So these measures included tracking number of patients seen in the clinic, monitoring the no-show rate, tracking number of patients requiring blood work, and monitoring the number of lab tests that we actually do per patient, assessing cost savings of reduced lab testing, and measuring physician satisfaction with the NP role in the clinic. Next slide, please. And the final question focuses on change. So what change can we make that will result in improvement? Next slide. So the changes that we introduced included reminder phone calls to help reduce the no-show rate and improve patient care, no limit on the number of patients seen in the clinic, expanded search for the most recent lab results prior to the patient's visit, selected lab work dependent on the type of anticoagulants that the patient is on, and a survey of physician colleagues. Next slide, please. So the second part of the model of improvement is the PDSA cycle, or plan, do, study, and act. So the planning and the doing phases I just reviewed in the previous slides, and now it's time to measure the changes or study. Next slide, please. Our first goal was to increase clinic efficiency. So with the initiation of reminder phone calls, and we were actually fortunate to have some administrative support for these calls, the no-show rate dropped by 95% to less than 2%. As you can see, our no-show rate was almost 20% every single day. And by pulling off this, very simple change, we were able to reduce it to less than 2%. And we saw basically the effect immediately. With the first day that the phone call started, we saw the no-show rate dropped right away. With our no-cap policy, we're now able to accommodate more patients per clinic. Previously, when we first started, the clinic was capped at 5 patients per day. We have seen as many as 15 patients in one afternoon for an increase of up to 300%. And this completely eliminated the need for an additional weekly clinic. With the craziness of COVID in the last year, we have seen some even crazier numbers of patients. I think the highest we've seen in the last couple of months was 20, so 400% increase in capacity. We don't really have any data on the wait list prior to the changes, but our wait list is basically now 0, and urgent consults are seen on the same day or the next day that the referral is received. The cumulative impact of these changes is seen in the final numbers, where we see an overall increase in patients seen annually. Next slide, please. Our shift away from generic lab testing to only necessary blood work resulted in the elimination of duplicated blood work and decreased number of lab draws per patient. After consulting with the medical director of the perioperative anticoagulation clinic, as well as the chief of hematology and thrombosis service at St. Joe's, patients on warfarin now only receive 1 lab test instead of 3. If you could advance the next slide. And only receive an INR if it hasn't been done in the past month or if the most recent INR was unstable. I'm sorry, Catherine, do you mind going back?
Sure.
Sorry about that. Thank you.
No problem.
Patients on direct oral anticoagulants or DOAC now receive only 1 lab test instead of 2, and only receive creatinine testing if not done within the past 90 days, because these are the study guidelines for DOACs. So together, these changes resulted in reduced risk associated for patients, including infections from the lab draws and anxiety from unnecessary and repeated blood work, as well as more timely clinic visits and reduced costs, of course, associated with the lab testing. Next slide, please. To help quantify these lab savings, we actually took count of how many patients we saw and how many patients needed blood work compared to previous. So based on this, we estimated cost savings. All based from the changes, patients on warfarin now only required INRs, and patients on DOACs only required creatinines. This resulted in basically immediate savings. So the total savings for these 4 months alone reflect simple lab tests only. They don't include the overhead costs of lab techs, nurses, portering, or fixed operational lab costs. So the $1,000 savings in the 4 months that we kept track of blood work are probably actually at least 3 times that. Next slide, please. The perioperative physician survey reflected high levels of satisfaction in the NPMD relationship. Most physicians have never worked with nurse practitioners before our role was implemented, so this was a refreshing change. The results basically reflected that they have a respect for our knowledge and skill in patient care decisions. They trust our decision making, and they have a high, and they think we provide a high level of quality care. Next slide, please. So in conclusion, with this QI project, we were able to achieve the following. The clinic capacity was maximized. We decreased the no-show rates, eliminated the wait list, instituted reminder phone calls. We minimized lab tests, which resulted in economic savings. We assured physician satisfaction and quality patient care. Next slide is my references, and I'll be happy to take any questions.
Wonderful. Thank you so much, Julia. Are there any questions from anybody in the audience for Julia?
Catherine, I have a question.
Yeah, by all means.
So Julia, a great presentation, writing some notes because some key takeaways, I think, for our practice here. I was curious, and just thinking about the lab testing, do you think that something along the lines of point of care testing for INRs, or that may be able to help even shave a bit more off of either time, or I'm just not sure about the impact on budget, but was that ever a discussion around point of care?
We actually know, that's a really good question. We've actually never discussed that, but I think the initial investment and the ongoing costs probably wouldn't be worth it. We don't have a warfarin clinic at St. Joe's. We do have a small pharmacy run warfarin clinic, but it's not close to capacity to, the Hamilton General Warfarin Clinic or the Juravinsky Hospital Clinic. So I don't think the initial investment and the ongoing costs would actually justify that.
Okay.
But thanks for the question. That's a great question.
Any other questions from the audience? Thank you so much, Julia. That was wonderful.
Thank you.
Okay, we move on now to Lan Zhao. So Lan is a nurse practitioner who works at acute pain management at Humber River Hospital. Lan earned her first nursing diploma from Sichuan University in PR, China, and Bachelor of Science in Nursing with Honors and a Master of Science in Nursing with Primary Nurse Practitioner Certificate from York University. She has more than 20 years of nursing experience in medicine, surgery, ICU, and post-op anesthesia care in Canada and China, and 8 years of experience as a nurse practitioner at the acute pain management team with Sunnybrook Health Sciences Center and Humber River Hospital, and as well at a geriatric clinic with the William Osler Health System. Lan has been an adjunct lecturer of the Lawrence S. Bloomberg Faculty in Nursing at University of Toronto since 2014. She has demonstrated her passion and expertise by mentoring and training NP students from the University of Toronto and Ryerson University. She has been showing her leadership and contributing to quality improvement programs in her workplaces. She truly practices her core values of compassion, respect, professionalism as a clinician. She also loves yoga and enjoys spending time with her family and friends, being in nature, hiking, and gardening. Thank you so much, Lan, for joining us. I will pass it over to you and advance the slides on your queue.
Thank you very much, Catherine, and also thank you for having me here to share about this QI project. So this QI project was studying about the opioid sparing modality for the perioperative acute pain management in primary hip and the knee surgery patient and my clinical practice setting. Next slide, please. So the background to initiate the QI project was the concerns of the acute post-op pain affect not only our patient general well-being, but also increase the perioperative mobilities, length of hospital stay, and the risk of developing the chronic pain. So the routine use of the opioids in the first-line treatment for the either acute or chronic pain and has caused more harm and also raising the opioids-related epidemic crisis. So we know there were many research have demonstrated the utilization of the opioid-sparing modalities for the perioperative pain management are safe and effective in minimizing these consequences. Next slide, please. So the purpose of this QI project was to implement the evidence-based pain management interventions to optimize quality of care and outcomes. So by utilizing opioids wisely and further advance the use of opioid-sparing analgesic strategies to reduce the adverse events and shorten the length of hospital stay. So this QI project would allow us to regularly review our results and also modify our interventions and in order to improve our patients' outcomes. It also promoted the further collaboration and communication between the Department of the Anesthesia and orthopedics and acute pain service in order to provide the both maximizing and the standardizing post-operative multimodal analgesia. Next slide, please. So the PDSA Plan, Do, Study, Act cycle was used as our QI strategy and methods. So at first we used a RICI ethics screening tool, which was formerly Alberta Research Ethic Consensus Initiative as ethical screening tool to evaluate and identify ethical risk for this project. So our score was 1, which means this project involves minimal risk to our participants. So the project criteria was focused on the primary hip and the knee surgery, which is not including the hip fractures, bilateral knees, and the revision and the same-day outpatients. We did a preliminary analysis as our clinic practice baseline. So there's like 128 inpatients selected retro perspective from October 1st to November 8th, 2018. During that time, the perioperative pain management intervention used at our clinic setting were all over the place. There are different providers use different pain management interventions. And for example, some like provider just provide preemptive opioids for everybody. And some will order the long-acting opioids pretty much post-op for everyone as well. And some just give Tylenol, NSAIDs, and younger anesthetists, some will practice peripheral nerve blocks and also spinal techniques. And some just use general anesthesia only. So therefore, our pain management outcomes were not consistent and ideal. In addition, the other team members were confused and also concerned about the variety of the pain management interventions and outcomes we have. So then there's like 95 consecutive inpatients selected prospectively from the May 1st to May 31st, 2019 for the first PDSA cycle. So during this cycle, then we start to introduce different practice, such as we decrease to prescribing long-acting and preemptive opioids. We start ending the opioid-sparing adjuncts. We increasing use peripheral nerve catheter if possible. And we also increase using the ice therapy, also called the prion therapy as well. And on top of that, we provided more pain education to the patient, family, and nursing staff about the multimodal analgesia strategies. Then again, there's 74 consecutive inpatients selected prospectively from January 6th to January 31st, 2020 for the second PDSA cycle. And during this cycle, we keep promoting the different practice with the use of the multimodal interventions and also enhance the communication between the 3 teams. Next slide, please. Next slide, please, Catherine. So according to the data from the QI project, the previous slides for the age demographic. Oh, thank you. Yes, the majority of the participants were at the age of the 60 and older. Next slide, please. So the total knee arthroplasty, the short term is TKA, and the total hip arthroplasty, another term is THA, which is all replacement, were the type of the surgery our clinic setting has been popularly performing. You can see the majority were knee surgeries. The knee surgery volumes were getting bigger every year, about 85% by the year of the 2020. And the hip surgery has been staying minority, about the 15 to 23% for the last 2 years. Next slide, please. For the hip surgery, based on the research literatures, the following regional blocks, such as spinal with or without epimorphine, or QL3-in-1 blocks, fascia-iliac blocks, or PEM blocks, recommended and encouraged to use for the perioperative pain management. Next slide, please. Next slide, please. For the knee surgery, adductor canal block, the short term is ACB blocks, with indwelling catheter was also encouraged and recommended to use for the post-op pain management. You can see the use of the ACB catheter at the time of the October 2018 and the May 2019 was stay at 33 to 34%, not much change. This is because some anesthesiologists were having doubt about these interventions, and some were not confident enough to perform these techniques yet. However, after we reviewed our first PDSS cycle results to the team and reassured the benefits of the intervention, and the more anesthesiologists were motivated to perform these techniques. So you can see from this chart that the use of the ACB indwelling catheter has been dramatically increased to 84% by the January 2020. Next slide, please. So the most positive outcome from this project was a significant reduction of the opioids average usage. So it was like a 24% of reduction from the first cycle to the baseline, and 44% of reduction from the second cycle to the baseline. So this result has provided us big motivation to continue practice the different interventions. Next slide, please. Another outcome from this project was improvement of the post-op pain level. Comparing to the baseline and the first PDSA cycle, the participant and the second PDSA cycle in the January 2020 had a better pain control, and the low one suffering the severe pain and not able to mobilize in post day 1 and day 2. Next slide, please. There were plenty of the research already proved the positive pain management outcomes of using ice therapy, which we call the Quion therapy post-operatively. At my clinic setting, the game-ready machine was the machine used to provide ice therapies. Unfortunately, because of the mechanic issue, we have short of the ice and we're short of the cough for the machine. We were only able to get the ice therapy data in the first PDSA cycle, which showed the better pain control with ice therapy at post day 1 and 2, comparing to the patient without ice therapies. Next slide, please. We also collect the data of the post-op side effect that patient experienced, such as nausea, vomiting, and the dizziness, drowsiness, pruritus, delirium. But interestingly, overall, the results haven't shown much difference. But the one we really look at is nausea, vomiting, and the delirium, which is from the 3 different time frame, and we do see improvement. However, the dizziness and drowsiness somehow still stay in the same kind of value there. So that's kind of interesting to say that. But I think the people has dizziness, drowsiness, because the age group we study, they're more elderly. Most time it's happen like orthostatic hypotension when they're doing mobilization. That's why sometimes delay, they have this kind of the side effect somehow is not really related to the opioids, but related to other medical issues. Next slide, please. So when we just start introduce this ACB indwelling catheters for the post-op pain management, the biggest worry we got from our staff, like nursing and physio, was if it affect the patient mobility post-operatively or delay the mobilization or discharge. Our APS team has provided continued education and reassurance to the staff. So by the time of the second PDSS cycle, actually you can see 100% of participants were able to mobilize with physio and post day 1. Next slide, please. And so comparing from the October 2018 to January 2020, the average length of hospital stay was shortened almost like 1 day. So that's a little change, improvement there too. Next slide, please. So then COVID-19 pandemic is coming and started. So everything had to change in the hospital, especially the surgeries. Prior to the pandemic, the implementation of the same-day knee surgery program, the short-term escape program, was already in the discussion and it works. A couple of anesthetists that has already initiated to some patients. However, with the COVID and COVID-19, to promote and expedite same-day knee surgery program would be the big plus to help decreasing the patient length of stay and the ramping up surgical service that were postponed at the start of the pandemic, and also avoiding a huge backlog of the surgery because COVID. So we start a pilot escape program in July 6, 2020. This program is just for knee surgery, the primary knee surgery patient only. The patient can return home the same day as their surgery with the use of the ACB in draining catheter and the running with an elastometric bottle, which is running with gravities for 3 days. And the patient will undergo physiotherapy before they leave the hospital, and to ensure it's safe to send them home. The anesthesiologist call the patient every day to check in, and on the 3rd day, and also provides their instruction to patient and their family members on how to remove the catheter and home, with no follow-up appointment required in the hospital. And the patient also have the number to call 24/7 if any concern arise. In addition, and the patient provide with multimodal medication along with nerve block system, pretty much used as Tylenol as a base. Patient also can rent an ice therapy game ready machine to go home with for 1 to 2 weeks as additional pain management regimens. This was covered by the private medical insurance. Next slide, please. So the pilot escape study data collected by the anesthesiologist from July to September 2020 is about 1.5 months data. It's pretty short data. It is actually showing 62.5% of the knee surgery patients were able to go home at the same day of the surgery, and more than 85 were able to keep catheter until the day 3, and most of them were able to would require some opioids during the 3-day period, and their pain was just mild, escape 3 to 4 out of 10, and they managed very well. Next slide, please. There were a small percentage of the escape patient has to be admitted to the hospital. The reasons for admission were late surgeries. They were unable to see the physio prior to discharge. They also maybe have some other medical concern like complex and past medical histories, or there's no family caregiver available at home and the same day. We also collect about 33 escape inpatient data from October 6 to December 2nd, 2020. The average length of hospital stay for those populations is about 1.48 days. So it's quite a big improvement compared to before. Next slide, please. And most of the escape inpatients' pain was well controlled, and they able to mobilize with the physio and the post day 1. And next slide, please. So in conclusion, our changed practice by promoting use of opioid-sparing modalities has shown positive outcomes. There was significant reduction on the opioids average use, and the improvement of the post-op pain control and the mobilization and post-day 1, even with indwelling nerve block catheters, and the shorten the length of hospital stay, especially with the SCAPE program. The SCAPE program allows patients to recover from the surgery in the comfort of their own home while reducing the potential exposure to the COVID-19. Certainly, we will still need to further monitor and follow up with our SCAPE program and modify our interventions as required to improve patient outcomes. In addition, we would encourage and promote to use ICE therapies as additional pain management regimen with the support from the research literatures. Thank you very much for listening. And thank you for being here. Any question for me?
Thank you so much, Lan. If there's any questions, please do put them in the chat or feel free to ask yourselves. Personally, Lan, as somebody that has knee problems and likely a knee surgery in my future, this is really encouraging to hear. And it's great to see all of the advances that you guys have made in using other modalities. I'm wondering, what was the most challenging part of this project? It just sounds so complex and there were lots that went into the implementation of it. What was the biggest barrier for you guys to overcome?
I think the biggest barrier is communications. And just because, like the participant for the SCAPE program, selection, the criteria, some anesthetists not really follow exactly. So some exclusion criteria, they still select that patient, and that's why, of course, people delay discharge. I think there's still so many little glitch we have to working on it. I think communication is the biggest part. Just to utilize 40 anesthesiologists, it's a little challenge. But however, we do see the good outcomes, and I think we're working on that. Hopefully, by monitor more and study more, then hopefully we improve this program. I'm not sure you guys reading the global news. Our SCAPE program actually is on the news. So really impressed about shorten the hospital stay during the pandemic. So which is, I think it's possible for us to change our, there's some kind of the things we need to improve. So definitely in the public, under the public eyes, I think we are working on that. It's a challenge, but we are working on that.
That's amazing. There's a comment from Catherine in the chat that says, fantastic way to pivot healthcare provision to meet patient needs during COVID. And I for sure agree. Thank you so much for sharing. That was wonderful.
Thank you for listening. Thank you.
Okay, we move on now to a presentation by Votrika Pajarapati and Sharmi Savaranthan. Please again correct me for any mispronunciations. So Ruchika and Sharmi are nurse practitioners in the Gusto Rapid Diagnostic Center at Princess Margaret Cancer Center. The aim of the clinic is to quickly provide patients with assessment and diagnosis of their breast abnormality to decrease the anxiety associated with waiting. Ruchika and Sharmi's role is to triage referrals, complete assessment, facilitate diagnostic workup, discuss results in management, and initiate specialist consults. Thank you guys both so much for joining us. I think I saw Sharmi, you're here. And yeah. Ruchika, you're here as well.
Yeah, hi everybody. My name is Pratika. Thank you for the introduction, and thank you for giving us the opportunity to present our abstract today. As mentioned, Sharmi and I, both of us are nurse practitioners and work in that capacity at the Gattuso Rapid Diagnostic Center at Princess Margaret Hospital. To give you a little bit of a background on Gattuso Rapid Diagnostic Center, it is an NP or nurse practitioner-led clinic. It began as a pilot project in 2006 to help streamline the diagnostic process for patients presenting with breast abnormalities. Now, these abnormalities could be screen detected on the mammogram or self-detected by the patients in form of a palpable lump or nipple discharge, etc., or a clinical examination by the healthcare provider. Now, you can imagine once an abnormality is found, the patients can experience a significant amount of distress, and the amount of time from the detection of an abnormality to diagnostic workup to final diagnosis can vary from days to months. And it is well documented in studies that women spend a significant amount of time in distress, which usually manifests as anxiety during this diagnostic phase. And it can significantly interfere with their day-to-day life until a diagnosis is reached. And the distress, of course, in part is due to the uncertainty and the fear of, the worst possible outcome, which is a cancer diagnosis. So GRDC was established with the aim to reduce the patient anxiety by improving wait times to diagnosis and access to care. So GRDC, it acts as a one-stop center for same-day clinical breast exams, mammogram, ultrasound, and a biopsy. And also the results are provided the same day and or at least within 24 to 48 hours. So our roles as nurse practitioners is to provide comprehensive assessment, take history, and provide physical examination. We work very closely with our radiologist colleague to facilitate the diagnostic workup. We are the ones to discuss the results and the management with the patient. And once confirmed it's in fact a breast cancer, we initiate the specialist consults, that is with the breast surgeon. And again, we are all part of one big team. So it's a very quick process to see a breast surgeon, as well as will be reflected in the study results that Sharmi is going to share with you. So the objective of this study was to assess the impact of the nurse practitioner-led rapid diagnostic clinic on the wait times from referral to diagnosis and from diagnosis to surgery. The method that we used was a retrospective study, which analyzed the one-year data on GRDC patients who underwent biopsy. And we used this data to assess the time intervals between referral to first initial to rapid diagnostic visit, and then from the biopsy to the diagnosis, and diagnosis to surgical consult. So I will hand it over to Sharmi, who will go over the findings of the study.
Hi, sorry we're not on camera because we're doing this in between clinics, so there's no camera access, so our apologies for that. So as Ritika has indicated, GRDC began as a pilot program in 2006, and then it evolved into this full-fledged NP-led clinical program in 2011. So we see about 5 patients per day, about 100 patients per month, and roughly over 1,000 patients per year. So when we began the program, we know we are going to see a large volume of patients. So the ratio, we knew that we were going to see about 60% benign and 40% malignant patient. And looking at the pie chart on the right for total GRDC cases in 2019, this sort of reflects, we saw about 47% out of the 1,066 patients we saw were positive, and 53 patients were negative. So negative means like, they probably still had a biopsy, but would require a follow-up if you look at the other pie chart. So, 36% of the patients needed surgery, but the other patients, it could have been a benign finding that requires follow-up, or even surgery. So that is reflected on the 36% as well. So, our wait times and the patient ratio have been pretty much constant since the start of the program in regards to referral to GRDC and GRDC appointment to diagnosis and initial diagnosis to surgical consult. So in 2011, for breast cancer, the provincial diagnosis interval was about 32 days, and we averaged about 1.2 days, where we can, like Ritika mentioned, we can give same day results where patients come in the morning, have their assessment and have their diagnosis, and even surgical consultation on that day if available. Otherwise, they'll get the results from the NPs at times, and then we refer them to the surgeons. And mostly we do see the patients with the surgeons as well. And the referral to GRDC, the average day was 5.8, as you can see on the chart. And that is influenced by many factors, like that could be because a patient has to bring, if they had outside imaging, they do have to bring their images for our radiologist to consult on them and to provide further recommendation. And once this imaging has been submitted, it takes about 24 hours for the radiologist to give us the consultation. Once the consultation is ready, we book those appointments. And that also depends on the patient's availability too. So we averaged about 5.8 days for that. And as per Health Quality Ontario, for wait times to surgical appointment after breast cancer diagnosis was about 9 days. So if you look at the bottom for initial diagnosis to surgical consult, we averaged about 3.8 days for patients seen in RDC and then for surgical consultation. So overall, like there are other rapid centers that have come up in the recent times, and there's published studies regarding these breast centers and their positive impact on wait times. However, like further research and the NP role needs to be highlighted in these settings, and that's what our clinic reflects, and we are still, doing further research regarding this to show the impact of the NP role in streamlining these patients. As NPs in the setting, we play a critical role in the day-to-day function of the program for the patient, and we take the responsibility of triaging the referral, assessing these patients, communicating between various team members, the pathologist, radiologist, and then also giving the patients the diagnosis and making appropriate referral to the surgeon. So once again, once surgical consultation is initiated, we are seeing the patients in the surgeon's clinic as well. So we do see these patients outside if the surgeon is not available, and then the patient accordingly. And then also, for instance, going back to the pie chart where it says initial treatment plan, there's about 8% of the population that we see that require neoadjuvant chemotherapy or endocrine treatment. That is in advanced breast cancer patients, where we need to provide systemic treatment prior to surgery. So we are also quite closely involved with the medical oncology patients, oncologist in sending those patients and organizing their metastatic workup, such as CT scan, bone scan, and any other interventions prior to sending them to the medical oncologist as well. So that's about it in a nutshell.
Thank you so much. That's a lot of work that you guys have summarized so neatly onto this poster for us, and it's very easy to follow visually. So thank you so much for providing all of this information for our audience. Are there any questions from the group about the nurse practitioner role in this clinic or about the study that was done? I have a question for you guys. Do you have any plans moving forward to continue collecting data and analyzing it? Or is there any type of like quality improvement framework that you look to continue using in the go forward?
So one of the quality initiatives that we're thinking of doing is, so usually prior to the initial appointment with our clinic, normally so what happens is a family physician, let's say, refers the patient to our clinic, and our admin assistant then contacts the patients and tells them the next steps. So one of the quality initiatives that we want to undertake is to assess the patient's anxiety levels. That is, so we want to set up two groups. So one group would be essentially who our admin assistant would contact, and the normal process of telling them what needs to be done. That is, bring us your CDs, we'll get them reviewed. Once that's reviewed, we'll book you in for an appointment, and then they see us, meaning Sharmi and I, on the day of the Gattuso rapid diagnostic appointment. That's the first time they see. So, and many a times when the patients come in, even before they have sat down on the chair, they break down because they're so anxious, thinking what this breast abnormality could be. So we're thinking of a project where we could start making phone calls. So Sharmi and I could start making phone calls upfront when we're suspecting a breast cancer, and sort of just prepare these patients for what a Gattuso rapid diagnostic visit will look like and what will be the next steps, as in it's cancer, how soon the results are available, and when do you see the surgeons by, and sort of, the potentials. So, and then compare those anxiety wait times to patients who received that upfront calls versus who didn't.
That sounds really interesting. Thank you for sharing.
Thank you.
There is another question from Sherry in the chat. She's asked, how has this research changed your practice?
So to be honest, it is helping us to sort of understand and sort of validate that we are sort of within the target, but then it's giving us further opportunities to explore the NP role and how we can highlight the role in this program, because we even did a study how the GRDC clinic sort of worked during the COVID time, like once mammograms were closed and so forth. So this clinic is a valuable clinic to patients, and not many rapid diagnostic clinics have, or I don't know if any of them have an NP role. So it changes it for the NPs, right, going forward, because many centers have come up after the introduction of Gattuso Rapid Diagnostic Clinic. I know there's a center where there is a nursing role, right, but not an NP role. And it's unique in such a way where, we can give the patients the diagnosis and get the process going even before surgical consultation, right? So if the patient requires an MRI, we can organize the MRI. And once the diagnosis is done, they are usually linked with a surgeon. But when we identify these patients really need medical oncology consultation, we kind of not skip the steps, but we expedite the medical oncology referral at the same time. So sometimes, we're looking into clinics where we can see those patients together to reduce the patients coming for multiple appointments, like a multidisciplinary clinic. So that's in the works too, where we identify, the NPs identify, okay, this is a locally advanced breast cancer, not a surgical candidate, but still needs to see the surgeon, then they can also see the medical oncologist. So we're looking into that as well.
Fantastic. Thank you. Thank you both so much. We do really appreciate it.
Thank you for having us.
My pleasure. Our pleasure, really. Okay, we will move on now to a presentation by Gina Pittman and Sherry Morrell. Gina Pittman is a graduate student and lecturer in the Faculty of Nursing at University of Windsor. Her dissertation work is aimed at illuminating nurse practitioner practice. She also practices as a nurse practitioner in the Windsor Essex community. Sherry Morrell has worked at the University of Windsor in the Faculty of Nursing since 2006. She is teaching in the undergraduate nursing program and the NP program. Additionally, Sherry has been the placement coordinator for the NP program for the last 4 years. Concurrently, Sherry works as a nurse practitioner in the community, most recently at Grand Marie Urgent Care and prior at the Windsor Regional Hospital Emergency Department. And Sherry also has some exciting news, I think, regarding her PhD as well. Is that right, Sherry?
Yes, that is correct. I just finished my PhD.
Congratulations, that's fantastic.
Thank you.
So I will pass it over to you both now, and I'll advance the slides on your cue. Thank you.
Thank you, Catherine. Good afternoon, everyone. This presentation focuses on our published scoping review, opioid prescribing safety measures utilized by primary healthcare providers in Canada. This scoping review is part of Gina Pittman's PhD research, and I had the privilege of collaborating on the review with her. Next slide, please. Oh, I got to advance my next slide too. The objectives for our presentation include reviewing why we selected a scoping review, the background related to the issue, the research question, and components of the study. Next slide, please. Why a scoping review? We elected to do a scoping review because this type of review helps to inform research. It identifies implication for policy and practice, identifies any gap in literature. Next slide, please. The next 3 slides discuss the background related to the importance of this topic. As you can see in this first slide, there are more than 13,000 opioid-related deaths in the first 6 months of 2019. Next slide. Oh, sorry. Additionally, from April to June of 2019, there were 389 opioid-related deaths. Next slide, please. Further, you can see by this slide that monthly opioid pain prescribing practices for new and overall users has not dramatically changed since 2013, even though we have ongoing information in the news daily about opioid overdoses and opioid related deaths. There hasn't been much change in our prescribing practices. Gina Pittman will continue with the remainder of this presentation. So next slide, please.
Thank you. So in order to guide our scoping review, we had to come up with a research question. So our research question was, what is the extent, range, and nature of literature available regarding safety measures utilized by primary healthcare providers when prescribing opioids in Canada? And as Sherry said, we selected a scoping review because for NPs prescribing controlled substances, including opioids in Ontario, it's a relatively new practice for us. You know, we were first allowed to prescribe in 2012, with Ontario being the last province to adopt this authority in 2017. So next slide, please. So for this reason, you know, given that the scope of NP practice has really increased dramatically since its inception in Canada, and the current overlap and scope between the professions of nurse practitioner and physician, we decided to focus on just physicians and nurse practitioners as the prescribers for this study. Next slide, please. So when reviewing the literature for a scoping review, you can include any type. It's not limited to qualitative or quantitative. It can include gray literature, including dissertations, really pretty much newsprint, anything that you can find on the topic. So we decided to make articles eligible if they involved opioid prescribing safety measures of primary healthcare providers for chronic non-cancer pain, that they were Canadian because we wanted to keep a Canadian perspective, and if they were published in English in the last 10 years, given that the inception of prescribing for NP started in 2012. Next slide, please. So we did a pretty comprehensive data search. So the electronic databases included the ones that you see on our screen there. So PubMed, CINAHL, ProQuest, Scopus, Open, Medline, and then the Canadian Electronic Library Collection. And then we completed some hand searches as well in relevant pain journals. We used Google, Google Scholar, Prospero, were utilized to identify that gray literature I spoke about, and additional search strategies included scanning reference lists for relevant articles as well. Next slide, please. So Sherry and I had previously completed the Joanna Briggs Institute training for their systematic reviews. So the systematic review manager that they use is Covenant. So first, all of our results were uploaded into the citation manager Zotero, and then we were able to import them into the systematic review manager Covenants, where after that we completed independent level 1 and level 2 screenings. So level 1 was just going through titles and abstracts to remove any irrelevant articles. Level 2 then was we had to read the full text, and as I said, Sherry and I were the independent reviewers. We had a third reviewer on standby for any to resolve any discrepancies. Next slide, please. So our study was guided by the PRISMA scoping review extension. So here's our PRISMA flow diagram. We started out with 329 records. After duplicates were excluded, we were down to 223. We determined that 192 were irrelevant because either prescribing measures were not explored, it was the wrong medication or population. So we ended up with full text articles at 31. And then after they were reviewed, we were excluded, we got down to 11. Next slide, please. So JBI also has, Joanna Briggs Institute also has a data synthesis table that is very useful for laying a matrix to perform data synthesis. So you can see there, we gave an example. This is from our published paper that they like it if you go across each article and look at the author, the year, the purpose, location, and population, what methods were used, the type of analysis, key findings, and then if it, the type of literature source it was. So we did that for all 11 articles that we included, and then we came up with some themes. So next slide, please. So the 4 themes that were identified in these 11 articles was that there is a lack. So firstly, all of the articles pertain to physicians. There was no articles that talked about NP opioid prescribing whatsoever. So the 4 themes that emerged were lack of physician knowledge and education regarding opioid prescribing for chronic non-cancer pain. There was one article in there that self-reported, it was a Canadian study, self-reported opioid prescribing practices, and they gave physicians a knowledge test on opioids for which they answered 2 of 9 knowledge questions correctly. That actual questionnaire was repeated late last year, and physicians still answered 2 of 9 questions. And they report that they feel that they lack the proper preparation for opioid prescribing and tapering. They also said that prescribing opioids is challenging due to some lack of resources in terms of consultation with pain specialists, those sorts of things. Given that Canada has a fee-for-structure service model, they said that this really is prohibitive in terms of giving a good patient comprehensive assessment and doing complex background for patients. And then in the US, several states have adopted emergency department specific guidelines, given that your interaction with the patient during those encounters is usually brief. So they actually implemented those in several states, but we have not developed any of those in Canada. Next slide, please. So further discussion, the literature, as I said, was basically all focused regarding physicians. When you look at the education, physicians felt that their education was inadequate and that their formal training, and that contributed to some of their feelings about opioids being challenging to prescribe. Canada could benefit from emergency department specific guidelines. There should be standardization of education regarding opioid prescribing and tapering. And there should be some implementation of mandatory guidelines regarding pain assessment. Next slide, please. So the solution to this is not linear. It's going to be a multifaceted approach where you need increased pain management education across these programs. It would be nice to have some pain community supports and services available for consultation and collaboration. There needs to be a review of institutional practices in terms of across sectors and across communities. Increased pain research funding. 20% of Canadians live with pain daily, so we could benefit from increased research in that area. And then NP prescribing research is essential to inform practice. What laid the foundation for my dissertation, which I have completed, which is with my committee. So I looked at, I sent out a survey that looked at NP opioid prescribing and safety measure utilization patterns in Ontario. So really trying to illuminate this part of NP practice. Thank you.
Awesome. Thank you guys both so much. Very interesting and timely topic. As I'm sure you both are aware, it's been a priority issue, opioid overdose and opioid deaths, the really high and unfortunate number of people that lose their lives to opioids every day. So this is very important conversation. Thank you guys both for sharing it with us. Are there any questions from the audience? So Gina, you mentioned that you are in the middle of completing a survey that's gone out to nurse practitioners, and was that Ontario-wide, or how did you find the nurse practitioners that are prescribing to ask them more about their practices?
So I completed, so I did a 3-phase study. I looked at quantitative and then informed it with qualitative data. So I've completed my study. I collaborated with the CNO actually. They have a process where you can collaborate with them once you have RAB approval at your institution to pay for access to their mailing list of NPs. They work with you to see what, what who are you looking for in terms of your participants, and they give you access to a mailing list of NPs who consented to be contacted for research. So I mailed out 2,100 survey postcards, and I set up a direct email address where they could email me to complete the survey online or in paper if they preferred. Everybody preferred to complete it online through Qualtrics. COVID had its challenges with, recruitment, because the majority of mailing addresses that the CNO keeps are workplace addresses. So I did a reminder postcard as well, but I ended up with 262 responses, with 158 of those NPs meeting inclusion criteria.
Fantastic. That's amazing. And I hope that you do have plans for publishing your findings afterwards, so we can all benefit from what you've learned.
Yes, thank you.
Awesome. Thank you guys both so much. That was wonderful.
Thank you.
All right. We are moving now. There's a couple of pages of references. However, we're moving now to a presentation by Salima Ladak. I want to make sure. Yes, you can hear me, Salima?
Hi, yes, I can. Thank you.
Wonderful. Okay, I will introduce Salima now. So Dr. Ladak is a results-oriented and award-winning nurse practitioner and quality lead for the UHN Department of Anesthesia Pain Program and clinician scientist PhD at Toronto General Hospital. With over 17 years of impactful patient care and leadership at the UHN and internationally, she specializes in the management of pain across wide-ranging acute and chronic health conditions, including pain in the context of substance use disorder. She was appointed to and currently leads the UHN Pain APN Network, a leadership team of advanced practice nurses who have been instrumental in enhancing institutional pain-related practice. Her research interests include post-operative pain outcomes related to function, understanding health professional educational needs, as well as program outcomes and impact. She is often a mentor to interprofessional staff, medical and nursing students. Salima was a founding member of the Toronto General Hospital Transitional Pain Service, envisioning the NP role on this interprofessional team. She is the recipient of numerous leadership awards. So with that, Salima, we'll pass it over to you. Thank you so much for joining us.
Thank you, everybody, and I hope that everyone's families are doing well. I will be brief in the interest of time, and wanted to present to you today the work of our team, really. So if we can advance to the next slide, you'll see that University Health Network is a multi-center site organization, and 3 out of the 4 centers have advanced practice nurses, which that are part of our University Health Network Pain Advanced Practice Nurse Group. And so really, if we advance to the next slide, I wanted to take you through where the journey started. And it wouldn't have been possible to empower nurse practitioner leadership influence without nurses who have stayed the course and created ways in which the leadership could be advanced through the years. And so the NP role made great strides under Dr. Mary Ferguson-Perret, who many of you might know. And that transitioned to the leadership that Dr. Joy Richards carries with us today. And so the work of the UHN Pain APN network has really been supported seamlessly throughout their transitions in the organization. And they've created ways in which the work of this network can be integrated into programs and unit-based practice, as well as through interprofessional teams. And so really, this is a tribute to their vision and their insight and their foresight of what is possible through the nurse practitioner role. And if we could pass on to the next slide. We have on the network, we have representation from Princess Margaret, Toronto Western and Toronto General, but it would be short-sighted to not to acknowledge past contributors. And so there's a legacy of this network, which I was appointed to lead as a nurse practitioner. And we've had NPs through various programs and services affiliated with pain management throughout UHN over the years that have made contributions to the work of this group and at their own sites, in their own programs, and their work continues, through the years, and we continue to build on that. If we can go to the next slide. The history of the pain network really started with addressing the fundamentals. As I've listened to the presentations today, it all comes back to the experience of the patient, whether it's through a unique program or at a systems level, in an organization. And so for us, we really had to take a look at the patient experience because our pain satisfaction scores were telling us that we were not providing the best possible care to our patients. And so during Mary Ferguson's, or MFP as we affectionately called her, during MFP's time, she created an opportunity for the nurse practitioners to be able to have a say and influence how nursing practice could evolve. And so specifically, she appointed an advanced practice nurse at the time to lead the group. And the mandate was to evaluate through programs that we were affiliated with at each site, what was the experience of patients, for example, through the surgical program at UHN related to their pain management. What infrastructures do we need to highlight that pain needs to become a corporate priority? And how do we advance that to the unit-based level? And she knew that we were trained, some of us that were new were still going to be trained on the leadership element of our role. And the expectation was that we provide our clinical expertise by bringing it to the unit-based and program-based partners to understand what their needs were in pain management and work with their teams to advance their own agenda related to pain management. We knew that we weren't able to, at the time, make a one-size-fit-all kind of shoe, but that it was possible to work both at the unit level and at the strategic corporate level. And so our mandate was to understand what the unit-based needs were amongst interprofessional teams. And we also wanted to make sure that our learners and new staff that were being onboarded at UHN received education at a basic level. And so this meant that they had to understand we had standards of pain management. UHN was the best spotlight organization of the pain assessment and management guidelines. So we translated those into tactical elements, meaning that, we asked for, this was kind of a victory looking back. We asked for time in the medical orientation of our new teams, as well as nursing teams. And obviously that's evolved in terms of the way content is communicated over time. But our learners and new staff are always taught about the fact that we have pain assessment and management standards at UHN. We also looked at the organizational level, how to standardize pain assessments. So there wasn't a real focus on how pain was being assessed or and documented. And so this was a huge sort of change in practice as well, and translation of best practice. And so we incorporated the valid numeric rating scale as our standard. And obviously in cases and areas where we weren't able to adopt that scale, we advanced the use of other, evidence-based standards. And so, for example, the FELT tool, in some areas, the FLAC tool for patients who are not able to communicate verbally or through written method. We also incorporated the use of our IPOP machines to enable translation of pain management. And so for a very long time, these mobile units were on all the floors. And since then, we've evolved to other methods as well. So really at the systems level, we looked at establishing practice standards. We looked at translating knowledge that was known at the time and it's evolved. We looked at interprofessional pain practice and how we were able to include different groups in any new strategies related to pain education. And so we always reach out through this network to our pharmacy, physician, and rehab colleagues to make sure that if there are new standards available, that they're aware of them, and where we can help as a network, we've linked up with these groups in the hospital across all of our sites. And so that's really sustained through the last, I would say, decade for sure. And as we change, our practice of education and our practice of care at the bedside, we hope to make sure that this actually evolves with time. We had, at a strategic level, I have to say that the impact was not measured using a nursing sensitive tool or a medical sensitive tool to evaluate, our improvement and our impact on patient care. We looked at the patient satisfaction surveys again, and we were happy that all the effort that was initially put in was, visible in the fact that there was a statistically improved advancement in patient satisfaction, and that we were doing well in certain areas. Following this, we made available through our teams the use of a validated survey that units could use on their own and use as a quality improvement strategy by assessing more in-depth the questions patients had around pain assessment and management, and to evaluate their experience. And this is now available to all of our wards. Of course, the strategy of this will change because we're kind of staying away from paper. And, despite the interruptions of COVID-19, we have made sure that basic, standards are still maintained through accountability of care at the change of shift, et cetera, and that our teams for pain assessment and management are available where required. Sorry, next slide. I've spoken to this a little bit, but what I wanted to sort of highlight to you was that we had to initially do environmental scans to understand where each profession identified their own gaps. And so this was really useful because it resulted in education days that were specific to key populations or key or individual practitioners or practice, what am I trying to say here? Individual practice groups. And so whether the medicine folks had a specific area where they lacked knowledge, we tailored knowledge to them to help them advance their practice in that area. We also strengthened professional capacity amongst frontline or point of care staff. And so we've graduated over the course of a decade over 200 nurses who joined our pain resource nurse program. And this was a 2-day program that was provided to nurses from all different programs and units, surgical and medical, as well as our TRI team. The nurses came to this program. They got more in-depth knowledge, and they were asked to identify gaps of their particular practice settings, to go back, and one of us on the network would mentor them in addressing the specific gap that they had. And so what they did is they worked with their interprofessional teams. Some of them wanted to do, I can highlight a surgical example where, we have head and neck surgeries, which makes communication very difficult. And so they actually created clipboards, and these still stay today in a different form, on allowing patients or enabling patients to identify their levels of pain and easier to communicate these. Another key thing that was tactical and a success for us at Toronto Western was that more severe pain in the clinical emergency presentation of the patient resulted in a faster triage system. And so that was a huge success as well. As we move towards standardizing our, charting and institutional sort of documentation programs, we're going to make sure that the work that's being done by the network isn't lost. And so we're all integrated into making sure that in addition to our specific pain program templates, acute pain, chronic pain services that we have, that the institutional elements of assessment and management of pain are translated as best practice into the upcoming EPIC program that UHN has decided to implement. We are also very focused. One of the key, I think, strategies that we chose was to empower patients with patient education. And so we also developed standards for patients that they would be informed at whatever entry point they had to inform any member of their care team, whether it's somebody from nursing, physio, transportation, medical imaging, housekeeping, that they had pain. And so we took it upon all of ourselves to make sure that if a patient or their family member noticed that their pain was worse, they needed faster help, that all of us were involved in communicating that to the right person on the ward or in the clinic. We also have, as NPs, now led the implementation of ERAS protocols, so that's enhanced recovery after surgery protocols. And at Toronto General, specifically, I can speak to the fact that we've now made available, because of the effort we put into strengthening bedside capacity, these nurses have been able to help us, and the pharmacy teams be able to help us advance NP-led programs like the implementation of intravenous ketamine as an opioid-sparing strategy and pain management strategy for post-op patients, as well as the introduction of intravenous lidocaine for the same reason, resulting in overall best practice in pain management through what we know of our research, as well as contributing to opioid-sparing strategies across the institution. And we hope to continue improving access to patient care through our transitional pain service. And we've now, through COVID, continued with that by making sure that we're able to link with our patients in an electronic way or through telephone calls. And I'll stop there to see if there are any questions.
Thank you so much, Salima. That was wonderful and a really rich background as to the network that you've been leading and this really important work you're doing in knowledge translation. It's very obvious that you have so much knowledge in this area of expertise over the last 17 years that you've been working in pain. And I think it's just so important that that knowledge isn't lost and that it's effectively transferred to other people in the network. So thank you for sharing. There's a couple questions for you in the chat. One is from Sherry Morrill. She's asked, is the EPIC program open to external nurses?
So the EPIC program is a specific electronic database that is UHN specific. And so this is where we will be writing our orders, charting on patients across programs and teams. And the goal is to really get rid of individual programs across departments and to get rid of paper-based charting. And so what it allows clinicians and patients to do is to be able to document from a single source. I think if you meant the pain resource nurse program, and is that available to external nurses, when we hopefully get through the immediate requirements of COVID, we'll continue professional practice development. And in the past, we did make available we had 10 spots available to our pain resource nurse program to external organizations. Also we had we want to be able to move it to interprofessional practice. You were interested, Cheryl, in the templates. Yes, we would be able to share those related to pain management once we have formalized them. So we're in the process right now, and I'm actually involved in developing our EPIC institutional, pain templates. So yes, I will be happy to share them once we're done.
That's fantastic. Thank you so much. In the interest of time, I think we'll move on to our last but not least presentation. Salima, thank you again. We do really appreciate it.
My pleasure. Thank you.
Okay, so we're back to Julia. She is providing us with a second abstract. So just in interest of time, Julia, because we did your bio already, we're going to skip and hope to keep this within the 2-hour mark. I hope that's okay with you.
Of course, I'll be brief as well.
Oh, no problem. Okay, wonderful. So you have the floor.
All right, perfect. So once again, I'm presenting on behalf of myself and my colleague, Lori Sardo. So if you could advance the slides, please. Because I am presenting about products, I have no disclosures. In 2016, Health Canada issued a safety alert for inferior vena cava filters. This was the reason behind our quality assurance and improvement project. All hospitals were basically encouraged to identify every patient they have had with filters and come up with a plan for filter retrieval. Next slide, please. Just a little bit of a background. Inferior vena cava filters, or IVC filters, as I'll be referring to them going forward, are mesh filters that are inserted into the inferior vena cava. They're indicated in patients with an acute proximal lower extremity DVT or a PE who have a contraindication to anticoagulation, such as bleeding or urgent surgery. They're generally used until anticoagulation can be resumed, so usually a temporary measure, but at times they do have to stay permanent. And their main goal is to prevent the embolism of a DVT into a PE. The Health Canada Safety Alert recommendations included ensuring that every patient who had an IVC filter have an appropriate indication and a plan for follow-up and retrieval. And they also recommended tracking all IVC filter patients. Next slide, please. Here are some of the goals of this QI initiative. So first of all, we wanted to ensure that all patients receive written documentation of IVC filter insertion with the recommendation to see a thrombosis physician after hospital discharge. The interventional radiology department, where IVC filters are placed, was already keeping a dedicated tracking database, which was actually compliant with the recommendations from Health Canada. As a result of the safety alert, we have implemented a mandatory thrombosis team consult for all IVC filter requests, and this was done to ensure that all patients have an appropriate indication for filter placement as well as an opportunity for follow-up. We also conducted a retrospective chart review to ensure compliance with the recommendations. Next slide, please. So the chart review was completed with the goals of determining what the indications were for insertion and ensuring they were appropriate indications, documenting the rates of filter retrieval, and identifying any complications. The REB approval was received in 2017 for this portion of the project. Next slide, please. The second part of the project was a patient survey, which was used to evaluate understanding of IVC filters, provide education to patients, and if they had any concerns, then to alleviate them, as well as identify any knowledge gaps that patients may have had. We also received REB approval for this portion of the project in 2017. Next slide, please. So here are the results of the chart review. In 2016, there were a total of 14 patients who received an IVC filter. These were all inserted for appropriate indications. So all 14 of these patients had either a DVT or a PE, and they were not able to receive anticoagulation. 9 of these patients had active bleeding events. 4 had planned or anticipated surgeries, and 3 patients had a high risk of bleeding, with one of these being a patient with brain mets, which causes a high risk of intracranial bleeding, and 2 patients having had recent bleeds. Next slide, please. So 11 of the 14 patients that had IVC filters placed, those filters were actually ordered by a thrombosis team member. For 3 patients, other teams ordered the IVC filters, but our team was involved and agreed with the recommendations to place the filters. These results were, again, 100% compliant with the Health Canada recommendations. Next slide, please. 12 of the 14 patients attended the thrombosis follow-up appointments, and the other 2 patients were palliative, so they had no planned follow-up. Next slide, please. 7 of the 14 filters were successfully retrieved. There were 3 failed retrieval attempts. So in 2 of these, patients had IVC thrombus identified during attempted retrieval, and 1 patient actually had a filter protrude through the IVC wall, so the procedure was abandoned. 4 filters were left in place with no retrieval attempt, and this was on advice of a thrombosis specialist. 3 of these patients were palliative, and 1 patient was suffering from persistent bleeding, so they were not able to take anticoagulation. Next slide, please. So the next component was the patient survey. And again, it was evaluating awareness of whether the patient had an IVC filter, what the current status of the filter was, their understanding of why the filter was in place, and the type of education that patients received about the filter placement. Next slide, please. 9 of the 14 patients were alive at the time of the survey, and 5 others were deceased. 7 patients and 1 POA completed the survey for a response rate of 88%, with the remaining patient that did not participate being a nursing home resident with no POA available. Next slide, please. Most were male, and the ages were fairly well represented between 35 and 85 years of age. Next, please. Most patients had either college or university education. Next slide, please. And 7 of the 8 patients were aware of their filter status, so whether it was still in situ or removed at the time of the survey. Next slide. Most patients were able to identify the reasons for their filter placement, with 6 of them stating that they had a blood clot. 2 people said they were bleeding, and 3 other people stated that the filter decreased the risk of the blood clot moving. So all of these reasons were correct. Next slide, please. All patients received verbal information at the time of the filter insertion, and everybody believed they received enough information about the filters, with 6 strongly agreeing and 2 agreeing with the statement that they have adequate information. Next slide, please. 7 patients preferred verbal education at the time of insertion, and 7 patients thought that a pamphlet would also be helpful in addition to the verbal education. 1 patient requested access to a website with educational resources. Next slide, please. So the result of the survey basically led us to develop this pamphlet, which is also available on the Thrombosis Canada website for patients and healthcare providers. These pamphlets are now given to every patient who goes through the procedure of IVC filter insertion at St. Joseph's Hospital. And these pamphlets basically answer the most common questions that patients have. So this includes what the IVC filters are, why they're used, the risks of the procedure, and whether or not they will be permanent. Next slide, please. So in conclusion, with this QA and QI project, we were able to make sure that St. Joe's is compliant with the Health Canada recommendations for all IVC filter placements when it comes to insertion, follow-up, and retrieval. And the patient needs survey showed us that patients were generally satisfied with the process and allowed us to develop educational materials that are now routinely provided to all patients and available for other healthcare providers to use for their patients as well. So next slide is my references, and if there are any questions, I'll be happy to answer them.
Awesome. Thank you so much, Julia. Are there any questions from those in the audience? Julia, I was curious, for Health Canada, they obviously advised you of the error or the issue. Did they provide any recommendations as to how your organization should go about approaching patients or following through with a big project like this? Or did you guys all mostly have to figure out all those pieces on your own after you just received the news from Health Canada?
They didn't really provide any specific recommendations. We just sort of went ahead and did it on our own. There was a pretty big uproar with all directors and heads of all different services, and they all came to the head of our service for recommendations as to how to move forward with this. So that's how the idea of the project came about. And then Lori and myself, we did most of the legwork in terms of doing all the, chart review and the patient surveys and everything else.
Wow. It sounds like a tremendous amount of work.
It was, yeah. It wasn't too bad because it was only 14 patients, but figuring out all the steps to get access to them and all the other patients that were screened, that was a lot of work for sure.
Absolutely. Well, thank you so much for sharing. Unless there's any other questions from the audience or comments, we will wrap up our spotlight on NP-led research and QI projects. To all of those of you that presented, thank you so much for coming, spending your time in this session, providing some information into your practice and taking the time to learn about others as well. We really do appreciate it. And we know that there will be many interested that couldn't attend today that will definitely enjoy watching the recording back. So thank you guys all so much again. We are now going to move into our NP preceptorship and mentorship session. So I'm going to actually just pause for 2 minutes. We'll get the new slides up and we'll make sure we have all of the presenters in the room and then we'll get started. So we'll take a quick 2-minute break and then we'll get started. Thanks, guys. Beth, can you just confirm that you can see my screen, please? Oh, you're just muted there.
Yes, we can.
Okay, wonderful. Thank you so much.
Looks great.
Perfect. Okay. We will get started. We do have all of our panelists and presenters here, which is fantastic. So welcome to the Coaching the NPs of the Future, NP Preceptorship and Mentorship session, pardon me. So today we are featuring Sherry Morrell. If you were here for the earlier part of our session, you heard her presentation as well as a bit of her intro. I will quickly reintroduce you, Sherry, for those who were not. So Sherry Morrell has worked at the University of Windsor in the Faculty of Nursing since 2006. She's teaching in the undergraduate nursing program and the NP program. Additionally, Sherry has been the placement coordinator for the NP program for the last 4 years, and she is working as an NP in the community as well, most recently at Grand Maurice Urgent Care, and prior to that at the Windsor Regional Hospital Emergency Department. And Sherry, we did mention this in the previous session, but has just recently completed her PhD, and we're very excited for her. So congratulations to Sherry on that massive accomplishment. We also have a wonderful response panel joining us today. We are joined by Catherine Lesser. She is a primary health care nurse practitioner who has worked in the emergency department at St. Mary's General Hospital in Kitchener since 2014. She previously worked at the Minto Mapleton Family Health Team from 2010 to 2014 after graduating from the McMaster University's Cupin program. Prior to this, Catherine worked at the Montreal General Hospital and completed her RN training at John Abbott College, followed by a bridging program leading to a BSN at the University of Ottawa. She has special interest in emergency medicine, refugee health, and the utilization of interpretation services in acute care. In her time as an NP, she has precepted students from McMaster, U of T, and Athabasca University. She is currently working on her certificate course through the University of Toronto on the care of the hospitalized adult and would one day hope to complete a PhD. So welcome, Catherine. Catherine is joined today by Teresa Barber-Pinn. Teresa Barber-Pinn graduated as a primary care nurse practitioner from Laurentian University in November 2020. She is currently employed as an NP at the Kirkland Lake Family Health Team in Kirkland Lake, Northern Ontario. She completed her undergraduate BSN in 2013 at the University of Ottawa and Algonquin College Collaborative Program. The majority of Teresa's nursing experience occurred at the Children's Hospital of Eastern Ontario in Ottawa in the surgical and emergency units. In 2018, Teresa moved from Ottawa to Kirkland Lake for a new adventure in starting the primary care NP program, and she is joining her spouse there, who is employed in the local mine. So welcome, Catherine and Teresa, our first mentorship duo. We also are joined by Renee Bradley and Delina Dang. So Renee completed her BSCN at University of Windsor and completed her NP degree at the University of Toronto in 2016. Her clinical background includes a variety of practice settings, including surgical intensive care, complex continuing care, and women's health. Renee is dedicated to increasing access to health services to racialized women. Outside of direct patient care, Renee is a member of RNAO's Black Nurses Task Force and a clinical instructor for George Brown College. Delina Dang is a recent graduate of York University's Master of Science in Primary Healthcare Nurse Practitioner program. Prior to this, she has over 8 years of experience as a registered nurse in emergency medicine. Delina is currently an NP in a corporate executive healthcare environment, providing holistic, client-centered care and personalized and preventative health management. Delina also provides comprehensive geriatric consultation for the Geriatric Health Assessment Program based at Baycrest Health Services. Her areas of interest includes women's health and sexual and reproductive issues. Welcome, Renee and Delina, our second mentorship duo. And last but not least, we are joined by Beth Sweeney and Amara Elnamera. So Beth Sweeney is a two-time graduate from the University of Toronto BSCN in 1992 and was in the very first year of the PHCMP coupon program in 1995. Beth has been involved in the primary healthcare nurse practitioner program as a member of the curriculum committee, a tutor, liaison, and now preceptor with the University of Western Ontario. Beth has always worked to her full scope as allowed by the legislation at the time and has constantly remained politically active. Part-time, Beth is the NP policy consultant with the RNAO. She works as a primary healthcare nurse practitioner, both with the Thames Valley Family Health Team, as well as Craigwood Youth Services, which is the youth justice system. Beth has a passion for healthy nutrition, exercise, friends, and family. And lastly, Amara, she is an entry-level NP in Southwest Ontario. She received her undergraduate degree in nursing from the University of Toledo in Ohio, USA. After moving to Canada and gaining experience through various practice settings, she was drawn to primary care and chronic disease management and chose to pursue a graduate degree in nursing, graduating in May of 2020. Her focus is on strengthening networking opportunities to help foster and support the RN to NP career transition, and she is passionate about advocacy for funding for NP roles to minimize the gap that exists for underserviced and vulnerable populations. We are so thrilled to have you as our third mentorship duo. So thank you guys all so much for joining us. We will start now with Sherry's slides, and Sherry, I will advance on your cue.
Thank you, Catherine. Hi, everyone. Thank you for coming to our afternoon session. I'm going to talk about preceptorship and mentorship, then we'll open it up to our panel for more discussion. Next slide, please. Oh, sorry. Yeah, you can leave it there. First, let's start with a definition. Preceptors are usually assigned. It's for a set period and it's usually a short time. They facilitate a preceptee's learning, focus on learning related to knowledge and skills. They're a role model during work time, and this can often evolve into a mentorship relationship. Next slide, please. So what characteristics do you think make a good preceptor? Can you type in the chat one characteristics that you think makes up a good preceptor? And then Catherine, you can hit the next slide, maybe. Okay, thank you. Thank you for answering, because this slide would have looked pretty silly if nobody put anything in the chat for me. So you can see that we've talked about expert knowledge, experience, they're approachable. Sorry, just pulling up my chat here. Every time I advance my own slide, I lose my chat. So very similar in what you guys are thinking is a preceptor. And next slide, please. So according to the RNAO, preceptors need to be competent, experienced, enthusiastic, have leadership and conflict management skills, strong teaching and role modeling, be patient and positive, have excellent oral and written communication, and lastly, be able to coach and provide constructive feedback. So you can see that a lot of the things you guys put in here were actually as well as characteristics that the RNAO feels is important in a preceptor. Next slide, please. Another question for you. College of Nurses of Ontario, are you obligated to precept? In the chat, can you please write whether yes or no is your answer if you think we are required or obligated to be preceptors? We've got a lot of no's. Does anyone have, oh, we've got a yes. Okay, so we've got a couple of no's and we've got a couple of yeses. Next slide, please, Catherine. So this was a question submitted to the CNO. I'm a senior nurse in my practice setting. I've been asked to be a preceptor to new nurses. Am I required to take on this role? Sorry about that. Okay, so next, thanks, Catherine, you're ahead of me already. So it seems to me that the CNO may be interchanging preceptors and mentors a little bit, and this is part of the answer. They went into accountability as well, but basically, according to the CNO's response, nurses are obligated to support learners. They have a commitment to their profession to upload the standards and are expected to mentor nurses and students. Next slide, please. So from that previous slide, normally we would think of preceptors as more in the academic field and mentorship more in the workplace. But by them saying you are obligated to do nurses and students, it almost looks like they're putting both together. So I would like to just give this information to you. We actually use this at the University of Windsor. This is a free preceptor education program through Western University. If anyone's interested, they can go on this site and it gives you a lot of information about being a preceptor. Next slide, please. I'm going to provide just a little bit of information about the NP preceptorship in the academic setting, because matching up a preceptor is not always as easy as it looks. There are multiple things that we have to consider when we are trying to link up a preceptor with a student. First of all, we have to look at the background of that NP student. Are they prepared for the settings that you might want to send them to? Meaning, where did they work as an RN? So for instance, if a student really wants to go to an ED setting, but they came from a specific RN background, say pediatrics or mental health or geriatrics, sticking them into an ED setting, especially in their first rotation, may not be a good experience for them. And I've seen it happen in the past where students feel that maybe this NP role isn't for them. And it could be, yet you just have to introduce them to the areas that they, not that they are so much comfortable with, but ones that they won't struggle too much with. The other consideration is experience of a preceptor. If they're novice preceptor, our first time, you don't want to necessarily overwhelm them. So we try to watch who we're matching up our preceptors, the novice ones, with the more experienced RNs or not experienced, because we want them to have a very good experience as our preceptors so that they continue to be a preceptor for us. We also look at what type of setting the student needs based on their previous site. So as they go through the program, we're going to look at giving them a mix, that they're not always going to go in the place they request. Students are always given the opportunity to request what sites they want to go in, but a lot of times they might pick a site they're comfortable with. And as they move forward, we have to know that at the end, they have to write a primary care exam. So we have to make sure, where did they go in the first one? Did they have family health team? Did they get the marginalized population? Did they have some pediatrics? So we have to look through the program at each preceptors they've had and what was their experience at that site. Finally, personalities. Sometimes there's a little bit of a clash with some students and some preceptors. So we like to look at what is the personality of the both. So for this to happen, you need to get to know your preceptors in your catchment area. If you are a person that's a coordinator and you're doing placements, you really need to go out and meet the preceptors and get a feel for their personality and get to know them. So it helps in our catchment area because I am an NP and I teach in the program. So I may have had a lot of the students and I may have met the NPs that are our preceptors through networking. So just a little bit of information on how the academic setting works. Next slide, please. Now we're going to move on to mentorship. And we're going to start with another definition. Good. A mentor is usually selected by a mentee, and it's usually for an extended period. So it's a little bit different than the preceptorship. They support the mentee professionally to advance them. They focus on the mentee's growth and development. It's a nurturing and a role modeling relationship, and it's usually done during personal time. Next slide. So if you're considering being a mentor, these are a few things to think about. Do you have a desire to share your knowledge and experience? Do you possess the ability to believe in a mentee's potential? If so, then you need to reflect on why you want to be a mentor. Next slide, please. If you are considering being a mentee, these are a few things to think about. Are you in need of a resource to help you navigate an NP role, a new or existing NP role? Are you in need of guidance achieving career goals that you may have? If so, you should reflect on why you want a mentor. Next slide, please. For those of you who've had the opportunity to be a mentee, can you please type in the chat one characteristics that you think made a good mentor? Okay, we're getting support. Enjoy their work. Excellent skills, good. Expertise in the field, good understanding, support, non-judgmental, right. And I would add to that, constructive feedback is really important in that as well. Again, next slide, please. Again, guys, thank you for the answers, since this was already an embedded slide. And you can see where you put your mentors and your preceptors, your answers are very similar. So even though we usually talk about preceptorship as a little bit different from mentorship, the qualities of a good preceptor and a good mentor are the same. Next slide, please. And these are the references for my PowerPoint. And next slide, please. Oh, okay. So I'm going to open it up to the panel. So now that they can discuss their personal experiences with preceptorship and mentorship.
Awesome. Thank you so much, Sherry. We're going to start with Catherine and Teresa.
Okay. Hi, everyone. Sherry, I'm not sure what you would have done if we had given terrible answers to your questions. Your slides were pre-done, but I'm glad that everybody stepped up. So as Catherine said before, I am currently a nurse practitioner working in the emergency department in Kitchener. I've been there since 2013. Prior to that, I worked for a family health team in a rural setting, and I came there from Montreal from a major level 1 trauma center. So it was a huge transition for me to move from a big acute care hospital into a tiny little primary care setting. My physician colleague was a town away, and so I really was quite alone during my novice time as a nurse practitioner. And I was very lucky to have another NP in the building who had about 5 years of experience, who was my mentor and who really shaped me and gave me the skills that I needed to become a successful NP. Just to kind of highlight the difference between what my expectations were back when I was in the NP program and what the reality of being an NP was like. I remember being in a class and hearing about rheumatoid arthritis and thinking, oh, there's no way I'm going to have patients with rheumatoid arthritis. Those are going to be for my physician partner, and I'll just be dealing with, you know, well women and children. And then I get into practice, and one example I can remember is having a phone call from public health asking me if I can see a 6-week postpartum Low German Mennonite woman who was having feeding difficulties. And I said, sure, squeeze her in. Friday, 10 minutes before the end of my work week. And she arrives with a stack of paperwork from Toronto because she had been in the NICU and had been admitted to the hospital during her pregnancy for multiple alloimmunizations. She had had 6 IVIV treatments. She had had intrauterine transfusions during the pregnancy. It was just a very complex case. And now this infant was there with feeding difficulties. And that's when I learned one of my favorite phrases in practice, which is, I'm going to step out and come up with a plan for you, and I'll be right back. And I was lucky to have Melissa in the building, and we were able to come up with a plan and work through the patient scenario. And we just did that time and time again over my first probably 2 years of practice until I became really comfortable with the role. I did really struggle at the beginning with being a novice NP, and there was an article that I had read that was called From Limbo to Legitimacy. It was a theoretical model of the transition to the primary care NP role. And I did find that the steps that were listed in that model did seem to be reflective of my own experience. The first step in that model was where they discussed negotiating the bureaucracy when you first become an NP. And certainly I had no knowledge about how to obtain a WSIB number or any of the other bureaucratic tasks that you have to take when you first start a practice. And then after that, the next step in the model is where they start to increase competence. And so my thought was always, at which point do you shift from being the mentee to being the mentor, from being the preceptee to the preceptor? And when we talk about competence in the workplace, you know, initially when you start a new role or a new skill, you're unconsciously incompetent, where you don't even know the things that you don't know. And then slowly you become consciously incompetent, where you start to realize the things that you don't know. Slowly, as you build skills and knowledge, you start to become unconsciously competent, and it's not clear to you when that transition starts to happen until you're finally consciously competent. And I think as an NP, because our role is constantly changing, we often have new medications, new treatments available to us, new patient scenarios. We are constantly moving through these steps fluidly. And so, you know, the Benner model of for novice to expert nurse says that basically around the 2-year mark is when you become more competent in your role. And I think that, you know, I actually didn't know that it was an expectation from the college for us to become preceptors, but I do think that it is our responsibility, if we have the opportunity to do so, to share with new NPs when they graduate. And I think the 2-year mark seems to make sense to me. So Teresa and I were linked formally through the RNAO mentorship program in December of last year. And the way that we decided to format our process together was basically just to meet by Zoom, because we're not geographically in the same area. Initially, we were meeting every 4 weeks. We slowly moved that to every 6 weeks. And I think that our next meeting is going to be more like 2 months from now. Because of my experience in having really relied on my mentor as a novice NP, I'm really happy to be a mentor through the RNAO. I've always enjoyed precepting students and have kept in touch with many of them over the years. And yeah, I'm thankful to the RNAO for coming up with this program, and hope that other new grads who maybe don't have as much support as others will be able to participate in this. So that's it. Thanks.
Fantastic. Thank you so much, Catherine. We really appreciate hearing from you and your experience going through the trajectory of preceptor or preceptee to preceptor. And I would love to hear now from your preceptee, Teresa. about your experiences being paired with Catherine, and even as a new NP. What were some of those challenges you found, and how has a preceptor helped you through them?
Hi, my name is Teresa. I'm at the Kirkland Lake Family Health Team. So when I graduated, I was kind of right in the middle of COVID, and I was hired onto the Family Health Team part-time. So I sought out the RNAO mentorship program, which was shared through our school, because I was currently trying to find another part-time job and wasn't really sure how to negotiate jobs or what job to look for, what to look for in a mentor. And so Catherine Lassard really helped me out in terms of what aspects to look for in a job, things to look at for like medical directives, and just having someone to talk to who had been through the process before was extremely helpful. I became very lucky with my current workplace. I was able to secure full-time employment within a few months. And I'm very lucky that I have several nurse practitioners to informally accept mentorship from. So similar to Catherine's experience in rural Southern Ontario, I can go and present a case to one of the senior NPs, develop a plan of care and follow up, and then present back to the patient as such, which is extremely helpful when you're new. In my case, because of COVID, I generally say I'm going to call you back because we're not doing many in-office visits, except for prenatals and well babies. With the added challenge of doing most telephone and virtual consults, that has been a bit of a tricky way to transition into a novice NP. And again, talking with Catherine about different ways to educate patients over the phone. For example, she provided me with a really excellent template on how to approach chronic pain with patients, which I found have made a very big difference. And especially being new, going from pediatrics to adults, dealing with chronic pain was something I was very new at and did require a little bit of guidance. She also provided me with a little template on opportunities to develop different chronic disease programs, or to investigate or learn more about chronic disease, which is another aspect that I realize I need more education on, especially coming from an acute care pediatric hospital. So having someone to bounce off different ideas from, just in terms of having support, monthly, month and a half, and then 2 monthly from someone who's been there has been extraordinarily helpful and alleviates stress because, you have someone to talk to who knows exactly what you're going through. And it really helps you feel secure and know that at some point you will develop that expertise and become someone that someone else will turn to. So becoming eventually a mentor is my goal, because I truly believe in teaching. Mentorship is a huge part of practice.
Fantastic. Thank you so much, Teresa. I think it's so crucial to have somebody there that can answer your questions when you're transitioning into a new role, because there's just so many things you unfortunately don't have the opportunity to learn about in school. And having somebody there that is available to help guide you through new processes is always very helpful. And it's just so nice to know that you can turn to somebody if you run into an issue, you have questions, you need support or guidance. So we're really thrilled that the two of you have been able to link up and that you'll continue your relationship moving forward. And Teresa as well, for you to hopefully maybe one day become a mentor to somebody else who joins the program. That would be amazing. Thank you. Okay, now we will turn to Renee Bradley and Delina Dang. We will open up for questions and more of a discussion with everybody towards the end of the session. We'll just go through our mentorship and preceptorship dyads first. So Renee and Delina, please go ahead.
Hi, everyone. So I graduated from the NP program in 2016, and I remember all too well the stress of trying to find my own preceptor. At the time, University of Toronto had us as NP students reach out to find our own preceptors, which was a really daunting task. And I always planned to precept NP students because I really think it's necessary to ensure that we have really well-trained NPs and that they have a very supportive environment to learn and develop their skills. But precepting NP students during COVID has been very different than pre-pandemic times. Typically, the focus has been on really developing that in-person assessment, ordering treatment and medications, ordering diagnostic tests, and really developing and considering differential diagnoses. And we would typically have appointments where the NP student would shadow and then start seeing patients by themselves independently and then consult with the NP after. But during the pandemic, we had to start navigating some very different workflows. And so, for example, portions of our day became that we had to do point of entry screening at the clinic. And then there was that mandate that came out that we had to start counting all of our PPE supplies. And so at the beginning, a lot of those duties were also with the NPs in our clinic. And so we were all a little bit concerned about how valuable NP placements would be, since a lot of these new tasks that we had to take on were not really in line with the NP scope of practice. And then we had to start navigating virtual care. So at our clinic, we didn't really have a lot of use for video calls, mostly because our clients don't have reliable internet access. So we found that phone appointments were definitely more reliable. But then this brought some new points of assessment in terms of having an NP student, because now we had to decide, like, can we manage this virtually over the phone without having the client come into the clinic, or do we need to book them in and see them and examine them in person? So it became really clear that having a really strong clinical background was really important for the NP student with navigating virtual care, because they were more familiar with kind of getting to those red flags and figuring out more quickly if we did need to see someone in person. And so Delina, my NP student at the time, had several years of experience working in the emergency department. So we could be confident that she was able to assess clients well over the phone with her clinical background. And then additionally, into clinical assessment, we have to start having different discussions in terms of navigating gaps in the healthcare system that became really noticeable with COVID-19. And the biggest one, I think, for us was a lack of mental health services that were really accessible for folks. And typically in primary care and in women's health, we do have a lot of appointments that are dedicated to mental health care. But then with COVID, we started seeing a lot of new themes, like more people discussing isolation, increased anxiety around just leaving the house or going for walks, going to the grocery store, increased stress related to having the kids at home. And then we had a lot of clients who were really impacted by anti-Black racism and then navigating this collective trauma. And so we found that some organizations were really great at pivoting their services to allow for accessible mental health care. And our organization did have some COVID response in terms of mental health. But then it was also interesting to see how the NP became more of the contact person for doing a lot more therapy and counseling over the phone and doing a lot more frequent follow-up. And so we had to do a lot of navigating that with our students as well. And then in terms of virtual care, we also started utilizing a lot more the OTN system so that we could do referrals to specialists virtually. And then that was really great in terms of looking at different ways to create a plan of care and ask clinical questions without having to send the client somewhere directly in person. And then I'll just hand it over to Delina for her perspective.
Thank you, Renee. Yeah, so hi everyone, I'm Delina. So going into integrated practicum was a monumental point in the NP program. It was the final placement before graduating and before going on to the licensing exam and registering as NPs and the last step before independent practice. My professors had stressed the importance of this last placement and how it was a chance to consolidate all of our knowledge, our skills, and our judgment. And it was also an opportunity to put into practice what we had been learning for the past few years. Unlike Renee's experience, I luckily was not expected to reach out to potential preceptors and find my own preceptors or placements or anything like that. Instead, we were asked to carefully reflect on our experience thus far in the program and select an area of interest or an area that we felt that we needed more learning in. And the school would try to match us with our preferred area of practice and other learning requirements. But the pandemic, of course, put a big damper on all those plans and all of our hopes. Suddenly there was all this uncertainty about our future and if placements would even be available for us, since many clinics were closed or had moved to reduced hours. Some clinics moved exclusively to virtual visits. So this idea of virtual care was such a new concept to my classmates and I. It's something that we didn't discuss at all throughout the program. And now we were being told that most of our final placement would have a virtual component. So the onus of orienting me to virtual care fell onto my preceptor, Renee. I had never conducted an assessment on the phone before, and I quickly learned that assessing a patient by telephone was nothing like assessing a patient in front of me. I couldn't see their facial expressions, I couldn't read their body language, and vice versa for the patient as well too. I wondered what the experience was like for the patient. Not only were they being assessed by a student that they had never met before, but they also couldn't see me and I couldn't do a physical assessment on them. However, I had the support of my preceptor. Renee has such a strong knowledge base and confidence that helped me feel comfortable in assessing somebody over the phone. She taught me strategies and tricks to complete a phone assessment, and slowly but surely it became the new normal for us. As I gained confidence in virtual visits, I found ways for it to work for me as a student. As I was assessing patients on the telephone, I could pull up resources and refer to different guidelines, something that I don't think I would be comfortable doing if the patient was in front of me. I think I would have to excuse myself and use the "I'll be back" excuse. I think overall, my final placement was wonderful. My takeaway from this experience is that one of the best aspects of NPs is that they're highly adaptable to new and changing environments. And not only that, preceptors in general, whether during COVID or not, are special creatures. They're passionate about teaching and they're so patient as the student develops their skills and their confidence.
And I think some things that worked well in terms of precepting a student during the pandemic, like at our clinic, we had 3 NPs. And so we were able to have Delina work with all of us. So she would just split her time. And that was great because it allowed her as a student to have more opportunities to have that in-person experience with clients, and then also have some virtual care or phone appointments. And that also allowed for more flexibility in the schedule, and then more potential to complete her hours, especially with the uncertainty of possibly having the placement end early. And in terms of virtual care, reviewing the cases briefly with the student was also, I think, really helpful, just to give them some pointers of how to approach this client that they've never met before. And then I think in terms of, having a student who's doing virtual care for the first time, you really do want to maintain their autonomy because, they are a registered nurse already. They are almost done their placement. So we did really want to have them do these appointments as independently as possible. And then, just create that support, knowing that this is something that's probably going to be a part of practice going forward. And then I think in terms of moving forward, utilizing more than one preceptor, I think during the pandemic is a really good strategy when trying to match students. especially if there's a rotating working from home schedule in place in the practice setting. And then hopefully as part of the NP curriculum, there will be some education around how to navigate virtual care.
Awesome. Thank you guys both so much for sharing your experience, and especially during COVID. I know that must have placed an additional stressor on both of you. But like you said, Melina, NPs are so adaptable and they're more than willing, from my experience anyways, to make the best of every circumstance. They're really doers, and they will just figure it out ultimately. And Renee, I'm sure you were an amazing preceptor, and it's so great to hear that you were open to taking on students during the pandemic, because we have heard a bit about just the stressors that are already in place because of the pandemic, and adding students to that load is not only another mental stressor, but it adds to the overall workload. And so I'd like to get into that conversation a little bit too after we hear from our final duo. Thank you guys both so much. So we will move now, before we get into more of an open conversation with everybody, to our final, last but not least, presenters, Beth Sweeney and Amara Alnamera.
Hi, everyone. So my name is Amira, and I am a novice NP and mentee to Beth. I came across the mentorship program not too long ago, probably the beginning of the new year, through a post actually in a Facebook group. And I was curious and responded because at the time I was looking for more direction on where my career path might take me, having just graduated. So I directed my questions to RNAO. They're very responsive and they helped facilitate a mentor for me. And it was super quick. I would say the process all in all probably took 3 to 5 days or so. And, and so being a new MP, no one's really there to show you the ropes, I'd say. Like, it's quite a murky waters of career change because we're experienced RNs, but very novice NPs. And so it's just a weird place to be in professionally. And so there's something about having somebody there to kind of bounce your questions off of, whether that's interviews or negotiating benefits, or what is an expectation, because there's a plethora of options out there on job sites that it's really hard to know what's the expectation. And then also to having that formal agreement between Beth and I, like, it helps to make us both accountable to each other and ensure that we're doing our best to achieve our shared goals. So that's really important. And she's been very, very helpful and supportive, and it's extremely valuable to have that partnership. So I'm super thankful.
Thank you so much. It's wonderful to hear. Beth, let's hear from you a little bit more about what this diet has been like for you.
Thank you. So as a very first grad in this coupon program as we know it, 95 is when I started. I did it full time. I've always been a member of the RNAO right from the first day when my undergrad began. I think I put my hand up to be the RNAO student liaison, right? So I'm really strong supporter and really think it's important for all students to get involved. I wished there were more students on this call, but all of the presentations are so exciting. But what I'm happy and excited about is that this portion of this presentation, I can put it onto a private Facebook group called the Preceptors and NP Students. So I'll get that from RNAO to post that, because this, from all of you speaking about preceptors, is really important. And now it's important to talk about this mentee-mentor program that the RNAO has put together. We're going to talk about it at the end, because this whole mentee-mentor program grew from our very first annual NP Institute. 2 years ago, it was at Niagara-on-the-Lake in a spa. So hopefully next year, NP colleagues, we can be back to 2 days, because we've got so much knowledge to share and learn. But the reality is, nurse practitioner students, when Catherine asked, what are the pros and cons of being a mentor? She asked if there was too much time consumed as a mentor, and I'll have to say no. As a con, that was not a con. I do not find that was an issue, and I still don't find that an issue. I absolutely love interacting with Amira as my mentee. So no, not at all. I would think the only con to being a mentor would be due to COVID and not being able to see Amira in person, take her out to lunch, have face-to-face conversations. We've had telephone and Zoom. And with my previous mentee, we were planning to see each other at the conference, but unfortunately COVID hit. So I have nothing else to say, but I'm going to go on with my pros. And so I do believe that it was a great help. I wish I had a mentor, which I did not. So I think just being a sounding board for Amira, and she has let me look at her CV so I could assist with her CV. I could assist with job opportunities out there. And also I looked for job opportunities. I'm constantly sending her things that I see that would relate to her and her location where she lives and her family life, etc. And also I said, hey, Amira, how about getting involved with the Nurse Practitioner Interest Group Executive? As a matter of fact, we had a co-chair position open with our chair, Sally Burr, who you've all met already. And what better way than to get more information, get networking with more NPs, that's what it's all about, and get beef up your CV than being part of the NPIG executive. So kudos to Amira. She put her hand up and we had her send her CV in and acclaimed because the process for voting had already finished. But congratulations to Amira, and she is now the co-chair of the Nurse Practitioner Interest Group. So that runs for 2 years and that's fantastic. What else have I got you involved in? I do believe that because of being a chair of the NPIG and you getting a responsibility, Amira, to post, she does all the twittering, guys, on the NPIG Twitter account. So getting that little responsibility had her set up to have a private conversation with our executive director, Doris Grinspun. And so I do believe that also is all flowing right from opportunities. And so I'm really happy that that happened. Now Doris has your number, Amira, and she is just so impressed with your professionalism and interest in the love of nursing and nurse practitioners. So that's a huge plus. When we spoke about this conference, right? When we spoke about this Nurse Practitioner Institute, I was, I must say, floored by the amount of even people in our executive that did not have professional development, paid professional development. And we brought that out to the NPIG Facebook group, and really it blew up as well. So lo and behold, from the reality of even you, Amira, you know, it's just a reality. It's timing. But 3 of our NPIG executive members, Patrina Barbas, Eric Staples, and Tina Zhu, they put together a resolution for the RNAO annual general meeting. And it was just announced to us as the NPIG executive that it was passed. So we'll put that out on our Facebook group. But it's passed, and it's all about the reality that nurse practitioners working in contract positions need professional development days. Okay, that is important. We're putting that through as a resolution. It's mandated, PD is mandated by our College of Nurses. And this is our annual NP Institute. We also have a Nurse Practitioner Symposium in November, but my dream and my wish is that every NP will come to this institute, and it has to be paid for. And that's what a professional development day is all about. So thank you again, Amira, for being my mentee to point that out, that was a nurse practitioner interest. And last but not least, I think another pro to having Amira as my mentee is, for example, having Amira here in the conference as a presenter, because Everyone is new to roles, and Amir's never done a conference before, so thank you for agreeing. When anybody is uncertain, right? And you have a mentor to say, come on, I will be there. I think it's important. And you agreed. So congratulations. And I thank you, Amira. So I want to just next pass the screen over to Catherine, because as I mentioned when I started, the reality is this entire mentor-mentee new grad opportunity started from 2 years ago at the NP Institute in Niagara-on-the-Lake. And it came from the members, the new grads, saying, we need this. So this is an example of the memberships talking and RNAO and NPIG listening. So this is an example of a letter. If you put your hand up or if you reach out, the letter that you will get. It's on the screen now.
Thanks, Beth, so much. And thank you, Amara, as well, for sharing your experience. We're so glad that you are part of the NPIG executive now and are sure that you will have so many opportunities coming from this, which all has really stemmed from the opportunity for you to be in a preceptorship relationship with Beth. So thank you guys both so much. I'll quickly show you the booklet that comes along when you do sign up to become a nurse practitioner mentee or mentor through RNAO's mentorship program. So we do provide you some overarching goals of the program, as well as some background why this mentorship program was created and who it's really meant to serve. We also share a couple of resources and some evidence, some literature that you can reflect on if you're looking to read a bit more about preceptorship and mentorship. What the program really does do is give a framework for the relationship. So it talks first about the pairing process. So how we do pair our mentees with mentors. We are always open year-round to having new applications. So you can apply online, and I'll also put the email in the chat as well if you're interested in either being a mentor or a mentee. But we are always looking for new mentors, and we're always happy to match mentors with mentees. We ideally do like to put pairs together that have similar practice interests or that are working in somewhat of a similar clinical area. It's not always necessarily the same specialty or niche, but we do try our very best to overall make the best pair we can in terms of clinical interests and practice area. We do provide as well the 5 phases of the mentoring relationship model, what that entails in terms of purpose, engagement, and planning for the relationship, including emergence and completion, and when the relationship actually is appropriate to come to completion, because we know that these mentorships, while they are really fantastic and do serve an important purpose, they don't need to last forever. And we do hope that those who are in the mentee position do ultimately become mentors to others as well. So we provide some other resources like this agreement template. So the newly paired mentor and mentee, if they'd like to, they can go through this together. They can talk about what is the purpose of their mentoring relationship, what they're looking to achieve, what are the expectations in terms of how frequently they'll meet, and some other maybe boundaries. Are we going to do this over Zoom? Can I call you if I have an urgent question? Really just outlining the expectations from the beginning so both are clear. And then again, going through frequency of meetings, expected length of the mentoring relationship, the preferred time and day, all of those logistical pieces that are really great to talk through at the beginning of a pairing, as well as thinking ahead about what might be some signs that there could be problems in the mentoring relationship. Maybe it's differing schedules, you're having a hard time connecting, just really thinking about those. We also know, as Sherry kind of mentioned, not every personality works well together in a pairing relationship. So thinking ahead about what might be some signs that you might want to address, although from our perspective, we very rarely do actually hear of really any issues. And we know that there are many mentorship pairs that go on to be quite successful in their relationship over time. We also suggest that you do a bit of an actions and time frame in terms of addressing any issues that may come up. We're also looking at the career vision, the medium-term career goal, and the long-term career goal. So there is some clear mapping out of where the mentee would like to be, and the mentor can have a good sense of how they may be able to provide support and help them reach their goal. And so this is the references that we've included. This package is available on our website. If you just Google RNAO NP Mentorship Program, you will see there is a link here that you can just click on. You can flip through some of the resources we have on the page. And if you are interested, I'll also put the email address into the chat box in terms of getting connected. Sherry, you have a question?
Sorry, I had to unmute. No, I don't have a question. I just wanted to add that the consortium that teaches the NP programs is developing some information for people, for preceptors who may be struggling with students as well. And I also wanted to point out that you might not find it happen as much now, but I know when I first started, there was no NP to help me. And when I came across something like wound care that I had no idea what I was doing, and I went to the physicians, they're like, we don't know any more than you did. I had to seek out additional learning. So kind of keep in mind that it's not always that you're going to find it from another person. You may have to take another course. You may have to take some more education till you feel comfortable and competent in your new role.
Absolutely. Thank you, Sherry. One other thing I did want to quickly mention before we get into a question is the NPIG executive has also been discussing the idea of an NP shout-out program. So rather than having a formal mentorship relationship where you are paired with a mentee more long-term, it would be more so of a database that could be accessible by NPs who are new to practice, or they just really need we don't want to call it a consult because it's not giving really clinical advice, but it is somebody who can listen to your situation, maybe provide a little bit of guidance or tell you what they've done in their past experiences. And so it should be something hopefully that the NPIG is able to move forward with, but we also would love to hear if that's something that's of interest to you, rather than having this really formal mentorship relationship, is having this NP shout out database where you can look at NPs who are experienced in different areas and really just pick up the phone and give them a call if you have a question or you would really just like some guidance. So that is something else that we are looking into as well. So we can certainly move into question and answers, perhaps if the panelists want to come on video, and we can have a little bit more of an interactive discussion, as well as any of the audience members. Of course, feel free to take yourself off video and or unmute yourself and join the conversation. We can kind of openly share some ideas about preceptorship here. So the first question from Susan is for Catherine Lessard. So you spoke to my experiences of moving from a large Ontario hospital, veteran psychiatric care, to Saskatchewan, small hospital, 1 RN per shift and doctor often out of time. My line became never say never. And remember, you are the patient's client's best advocate at the moment. Have always enjoyed new staff. Keep up the good work. All right. Yeah, any other comments or questions for the panelists or for each other? Can I ask if the audience members are new NPs, and if they are new NPs, if they have found a mentor either within their workplace or through their own other networks? And if you're not a new NP, if you're an experienced NP, if you currently have a mentee or have been approached about having a mentee? Any thoughts, anybody?
I would also be interested in knowing what sort of perks or compensations you get from your workplace for being a mentor yeah.
Mm-hmm. If there are any, for sure. That's
if there are any.
Mm-hmm.
You mean preceptor?
Well, even mentor if it's associated with your work and they ask you to do it. Preceptor at our university will give like library access, and I know other universities do, but some like the hospital asks you to be a mentor of a new employee and they'll pay you like, I don't know, 50 cents an hour to do that. So I was just wondering if other facilities have something where they get some sort of perk for being whatever your institution calls it, a preceptor of a new employee or a mentor if they use that phrase.
Mm-hmm. Great question.
So post-grad is the question.
Yeah, post-grad.
Catherine, do you have the opportunity to to mentor any new NPs that come, or is your team a little bit too small to have that kind of opportunity?
No, I've onboarded probably, I'd have to think about it, maybe 4 or 6 NPs over the past few years. And I don't think there's been any additional compensation. I've never questioned it. I know that I'm an ONA member, and so through ONA, if you are an RN, if you have a student nurse or a student NP, then there's something like a 23-cent an hour incentive, which basically ends up paying for lunch on the last day. But I've never asked if that also was for onboarding new staff, so possibly, but haven't explored it.
Mm-hmm.
And really the financial incentive is not there to even bother asking the question.
Is there something else, if you could think of anything, like is there something that would really drive you to want to be a preceptor, apart from just doing it, out of the goodness of your heart and to give back to those because you received preceptorship when you were in need?
I think what Beth was speaking about just with having access to continuing education, I think that's the biggest thing for NPs in the hospital. They, we want to have, our hospital expects us to have the expertise of, at a similar evidence-based level as our physician colleagues. And yet we often work longer hours, we have lower remuneration, and we are employees. And so we can't put the cost of conferences and education on our taxes the way that our physician colleagues do. So it costs us financially in order to better ourselves and become more educated. And I don't have any firm commitment from my organization for time even. So it's time and it's personal finances. So I'm excited to hear that there's something coming.
Thank you. See, that surprises me again, that it's not already like pre-written in when you signed up. And sometimes new grads don't even think of that as part of their employee and employment contract.
No,
we're just happy to have a job.
Mm-hmm. Yeah, and it has been brought up and the answer has just been no. We have the same level of access to education as our RN colleagues in the hospital.
In the hospital.
Yeah, and I will tell you, when I first started as an NP, we were not in ONA, not saying anything against ONA, and we had 5 education days paid for, and they paid for our conferences. And as soon as we went into ONA, we lost that. And now we get the response where, no, it's not part of your contract. So we no longer have that. So it is a big concern, because we need to stay relevant, and there are some really good conferences and workshops and just additional learning that you want to take. And I don't mind taking it on my own time if it's available, but often a lot of it is during your work time or during your work schedule, and sometimes it's hard to adjust it. So that would be a really good benefit to, I think, all NPs. And you brought up a really good point, Beth, that maybe when you are negotiating your new hire position, that's something you consider. Like what do you offer as in way of education days, or do you pay for a conference once a year, or that sort of negotiating compensation?
Absolutely. That as a senior nurse that would be like absolutely 100% necessary for me to take a role.
That's a great point.
I also want to say to everybody and put it on the tape that the RNAO AGM is where we have to definitely commit to our time frame next. And that is June 24. Opening ceremonies is at 6 p.m. Then June 25 is the AGM at 4 till 7. So that's key, that we all are going to be there to vote and talk about this resolution. There's lots more than just ours. There's fantastic resolutions. And June 26th is closing keynote from 11:30 to 1. So registration is open. I'm certain that everybody on this call got an email from the RNAO. If you go into your email and just put in the keyword AGM, it'll come up for the 96th annual.
Thanks, Beth. That's it's great to mention, and I appreciate you mentioning it to provide a little bit more information to those who may not know a lot about what happens once a resolution is passed. It does mean that we get the clearance as the policy department to start really looking into the resolution and what type of action we can take to advance the resolution and to meet its objectives. So that often involves working with a variety of stakeholders and working with the movers of the resolution to come to some type of really achievable goal that does help to see positive impact towards the resolution. So with that being passed, you guys will hear a bit more about it at the AGM, and then really the policy department at RNAO, as well as the other departments such as the research department, are often involved in terms of finding actionable ways that we can move resolutions forward. So very glad to see an important resolution towards continuing education has been passed, and there will be lots more action, I'm sure. Jane has left a comment here in the chat. So she said, I wonder if the RNAO can work with the individuals running the NP consortium. I find that most new grads find it a huge challenge going from NP school to practice. Not only are we learning to be an NP, but we're also completely learning a new role. And often we're not set up for the bureaucracy that unfortunately does come with the role, i.e. discussing compensation, negotiating salaries, etc. I think we need more education on this. It's an excellent point. Jane, is that something others feel the same way about in terms of having an opportunity to learn a bit more, maybe the skills in terms of negotiating salaries, or what would be most useful to you guys in terms of supporting you? Would it be like workshops, webinars? What types of things do you think, Jane, or anybody else who might also be experiencing this?
Hey, Catherine, Arik here. I think, and I don't know whether this is out there, but I think having like a document that helps kind of has some key talking points for interviews would be helpful for students, or new grads rather. Just when you're sitting down, this isn't something you learn, about sitting down and negotiating, how much you should be paid, benefits, education days, things like that. So some of those key kind of points and maybe some strategies, don't come right out and say, show me the money, how much you're going to pay me, but different approaches as to how you might negotiate that, what the funding is, maybe some speaking points around, what is the available funding typical, so NPs are aware of, what organizations can be provided, the max amount for NPs.
Absolutely. That's a really great point, and something I will definitely bring back. Something that I found interesting over the course of working on the nurse practitioner task force in the last year was unfortunately a lot of NPs don't really know all the specifics of the funding or even what kind of funding model they're operating under. So having a good understanding of that for sure allows NPs, in my opinion anyways, to better advocate for themselves if they have a good sense of where the funding is coming from and what all it allows for. There are a ton of different ways that nurse practitioner roles are funded. So that is certainly something that I'm sure would be useful for every NP to understand. And having some type of document that maybe will outline that and asking how to ask those types of questions. We'll definitely take that back. Thank you for the suggestion.
Thank you. That's a really good point. I think what I was trying to say is there is a course in the NP consortium. I can't actually remember the name because I've graduated a few years ago, but it does talk about the specific roles of the NP versus some of the other healthcare professionals. But I find that with that course in particular, there's too much focus on things sometimes that doesn't, it's not really relevant when it comes time to practice. So I do think that the funding model, the operational logistics and things like that would be very important discussions to be had that we don't focus on enough. So even things like physician billing, for example, and not being able to bill OHIP for services, I find that even new grads sometimes still get confused about that. And one reason is because we just don't focus enough on all of this. So as you probably know, the funding model for family health teams versus like hospitals versus other types of centers, they're all quite different, and we just don't have enough knowledge about all of this.
Absolutely. No, that's a really good point, Jane. Thanks for bringing it up. I wonder if Sherry, or I know Gina is still on the line here, from your perspective as an educator and somebody who maybe delivers that course, could you see there being, is there time? Maybe that's the question. Is there time? Because I know the NP program is so, it's really jammed packed as it is. Do you see there being time to include some type of lesson or curriculum around that?
Yeah, what we do in our last course, the integrated practicum, now it might vary per institution, but what we do is we have one day where we bring back someone who recently graduated to kind of go over those things. How did I apply for my license? How did I get my WSIB? What questions do you ask at an interview? So in our last course, we kind of have one of those that kind of look at that, and we bring in a newer grad to say, how did you go through it? And it becomes one of our topics for one of our days. I'm not sure if all institutions do that, but we recognize that as our students asked us for that when we asked, how can we improve this last course? And that was something exactly like Jane said. They need more information on, how do I ask what lab tests you do? How do I everything that you want to ask, but you're often afraid to ask. Is it okay to negotiate a salary? What happens if they don't want to not get the job, but they don't want to go in a job and then find out they don't have a mentor, they don't have resources, they don't know how to get their WSIB and things like, do I bill for my WSIB? Does a physician bill for my WSIB? How does that work? So I don't know about other ones, if anyone can speak to it, but we certainly have added that into our program.
I really think it would be beneficial to have some kind of a primer on the things that our patients have access to that we don't know about through Service Ontario and things like that. So I had a patient who didn't know that he had, that he could apply for the old age security, and he was like 69 years old. So he went 4 years with a really, missing out on whatever it is, $865 a month for years. And he was pinching pennies, having difficulty paying for even his basic costs of living. So if we're addressing social determinants of health as nurse practitioners with our patients, but we don't really know the entire healthcare system and knowing who can apply for CPP, when can they apply for CPP disability, it's hard for us to guide our patients when we don't understand it ourselves.
That's a great point, Catherine. Thank you. There's a couple more comments. I'll go through them and see what conversation ensues. So there's a comment from Maureen. We are caught that as employees, we can't claim all the things that MDs can on your income tax, and yet we don't get everything the RNs get as an employee. Can you maybe explain that a little bit more, Maureen, or does anybody else have a similar experience?
Sure. For instance, MDs can claim pieces of equipment they buy. Like if you have to go buy a new stethoscope, or you want a pediatric one and an adult one, or you buy other supplies for in your practice, you can't write that off because you're not incorporated as a business, you're an employee. Whereas physicians can claim all of those things off their expenses, off their income tax. Education, you can claim the tuition part, but you can't claim the hotel part if you went to go to attend a conference, whereas they can claim the whole thing. And so there's a real discrepancy because we can't bill OHIP and they can. And so how we get paid has made the tax system also impact the things that we can claim.
Thank you, Maureen. There's another comment potentially including a webinar regarding this during the roles course. So I think, Sherry, it sounds like your university has effectively included some dialogue around that, but perhaps that would be something for other schools to consider as well. Do you network at all, or are you in connection, Sherry, with other faculty across the consortium of nursing?
Yes, both Gina and I are actually on a committee looking at stuff across the consortium, so we can bring that forward. And we meet as a team in August for whichever course you're teaching. So every single person teaching that course. So we can bring that up at that as well to the course leads and say, you know, can you look at this? This has been brought up at the NP Institute. And can you look at not just one site doing it, but all sites doing it?
Awesome. Thank you. Okay, there's another comment from Briar. Would this preceptor mentee program be applicable to NPs interested in pursuing a PhD or DNP? I would say yes, of course. There is lots of NPs that do have doctoral training. As we know, we had a number of them that were actually on our abstract presentation today, which was really great to see. Sherry, Eric, Gina being just 3 of them. I know there were even more beyond that. So yes, we're very lucky to have a wide network of NPs at RNAO that are pursuing doctoral studies, some of which are available as mentors in our NP mentorship program. If that was something you were specifically looking for mentorship on, you could certainly just let us know that when you do go through the application process, and we'll do our best, like I said, to find you an appropriate match. And if you were to apply and there wasn't a really good match for you at that time, we do everything we can to reach out to our network and try to find somebody that would actually be a good match for you and that would be willing to be a mentor for you. And we typically are very successful in terms of finding appropriate mentors for people if we don't have one that's already in the pool. So that's a great question. Thank you for asking. Let's see if there's any other comments that I've missed. So Beth has made a comment. We do have another NP Insider coming up. It's May 6th, 2021. At 4:30, we do have a lap lawyer coming and they will cover some different issues, including nurse practitioners and independent practice, prescribing for family during COVID-19. There's been some questions about that to RNAO during the pandemic, so it will be a really great session to kind of get those questions out to somebody that can actually advise properly on some legal ramifications around that. So thank you, Beth, for mentioning. Yes, we can. So there's, Sherry, there is the NP program. Sherry's question was, can we include a link for those who want to sign up to the RNAO mentorship program? I'll include the link to the package and then I will resend the email address. So the email is npprogram@rnao.ca and it gets forwarded to the appropriate policy analysts that are working on the files to do the matching. So I will resend that email and I'll also include a link to the program as well. Thank you. Were there any other comments about preceptorship or questions about mentorship? There was something I did want to ask kind of more broadly to the group, and it was about managing the extra workload of taking on a mentee during a pandemic. Is that something any of you guys have personally experienced, and what kind of strategies have you used to work through the added kind of time and sometimes pressure of having somebody that's looking to you for support?
I think for myself, I can say that if anything, the pandemic has normalized Zoom as a method of communication. And so in a sense, it's just kind of helped to normalize or help with the experience of having a preceptee or a mentee that's not in my geographic location.
And Sherry, are you guys, do you guys have a fairly easy time finding preceptors? It sounds like you maybe use a similar pool of preceptors in your area time and time again, or how do you go about recruiting new preceptors for the university?
I don't know if Gina wants to jump in on this because she took over the role for me this year, but generally I'll let her answer this one.
Lots of begging, offering, children in exchange for somewhat, especially during COVID. It's been very challenging. However, you know what? Like to kind of promote us, as we have our students graduating, we kind of remind them, in a year we might contact you to see if you're feeling ready and in a position once they get a job, because they usually all email us to tell us when they obtain employment. So I usually put the plug in then that says, well, maybe in a year, once you're comfortable and established in your role, we might contact you for, to be a preceptor for our students. So I kind of try to start the conversation early is usually my method.
A good method. And have you noticed, has it been more challenging during the pandemic?
Very, very much so. We got a couple of things happening here in Windsor. We have a lot of agencies that are not permitting students to come in whatsoever. So they've been closed to us since the beginning of the pandemic. So a lot of our community health centers, which have great NP placements, have closed the doors to us. And we're in a unique position down here in Windsor because we have a lot of NP students that work as RNs in Detroit. And that's the other challenging factor for us. Despite all of our students that have worked in Detroit are double vaccination, right now in Windsor, agencies are giving us the hard no. If you work in the US, they're expecting you to take a leave of absence, quarantine for 2 weeks, and then not work during the entire time that you're at clinical practice. So it's been challenging. We had a couple of students, so we had to supplement with virtual down here to help students achieve their hours. And we did have a couple of students that did take an LOA. So they did the 2 weeks of quarantine and then did a consolidated period with their preceptor where they went for 3 weeks full time to get hours, and then they had to go back to work. So that's how we've kind of mitigated that down here. But for IP, they all take an LOA anyway. So we're right now, knock on wood, we're in an okay position for IP.
I'm so glad for you, Gina. I'm a preceptor with Western, and I'm with the largest family health team in Ontario. And when not my office, but a lot of the offices sent the NPs home, even if they wanted to be preceptors, they weren't equipped. I mean, it was just like, in the next day, they were sent home and working from home with kids without childcare. It just didn't fit. So I was blessed, but the reality is that my student who's on this conference, not in this session, she did have to take that 2 weeks off as an RN. And so it is very, very different during COVID. I think we as nurses and as nurse practitioners, we are lifelong learners. We all want to give back. We know how important being precepted was for us. So I don't know of any colleagues that won't be an NP preceptor. They might not take it time after time after time. But I do think it's our duty, right, to give back to our profession. It's our duty.
For sure. And as we learned from Sherry, it's to some degree definitely also expected by the College of Nurses. So thank you guys all so much. Are there any last questions from the audience or from any of the panelists to one another before we close out? I'm not seeing any. I wanted to give a sincere thank you to all of our panelists for joining us today, and to Sherry for giving us our opening keynote. It was really great to hear about preceptorship and mentorship and why it is so important for NPs, and to really coach NPs of the future. We know there can be challenges during COVID. We heard from Delina and Renee about adapting their assessments and how that can be a bit tricky, but like they said, NPs are amazing. They will adapt to any situation, and they've really just shown through during this pandemic. So we would encourage you guys all to consider being a preceptor or a mentor if you're in a position to be one, or to otherwise reach out to us or within your networks to see if you can connect with somebody who's willing to give that guidance to you if you yourself are looking for some support in your role. And of course, please feel free to access the NP mentorship program that we do offer through RNAO. It is available year round, and it's an awesome way to get connected. Thank you guys. So our next session is at 3:30, so we have about 5 minutes. I'm going to send, the link is in the chat now to where you can join back. Just make sure you have the meeting ID and the passcode, and we will get started in a couple minutes, just probably after 3:30 on our main Zoom link. We'll all come back from our concurrent sessions and finish with a closing keynote from RNAO's CEO, as well as from Dr. Alyssa Ladd. And the session is going to be focusing on the Nurse Practitioner Task Force report. And we're actually going to do some interactive exercises to talk about how we can prioritize the recommendations from the report. So it's going to be a fun session, and we're going to close there. Yes, Beth?
Don't leave, everybody. We are just blessed because I just got to share with us. This is Catherine's last hurrah, and she's doing it all for the entire day. But we, as a small group, I just want to let you know that she's leaving RNAO to go back to practice in the community. So Catherine, you're just such an amazing person. Thank you for being you, and thank you for being such an amazing moderator.
Oh, thank you, Beth. That's so sweet. It's been a real privilege to work with you and to work with everyone that's so well connected to RNA. I hope we can stay in touch for sure. Thank you.
Absolutely. Oh, there's hands up here. Crying. Oh, is that clapping? That's clapping.
It's clapping. Thank you guys. Okay, we'll see you back in the concurrent session. Thanks so much for joining us.